Hello. I extend a very warm morning to the chairpersons and all the presenters and the participants present here. My name is Raja Rampi. I'm a PhD scholar at the Department of Clinical Psychology, Rimpas, Ranchi. I will be presenting a paper titled An Eclectic Psychotherapeutic Approach in the Management of Comorbid Sleep Terrors and Non-Organic Enuresis in a Child with Separation Anxiety Features, a single case study. This case was supervised by Dr. Masuru Jahan ma'am and Professor Dr. Amul Ranjan sir. Sleep terrors and non-organic enuresis in children often reflect underlying emotional dysregulation and anxiety-driven conflict, particularly related to separation or fear of loss of control. According to biopsychosocial models, sleep terrors can be viewed as stress-mediated arousal phenomenon arising from anxiety and environmental instability. Psychotherapeutic approaches integrating play therapy, behavioral modification, and hypnosis have been shown to enhance self-regulation, decrease parasomnias, and reduce secondary anxiety in pediatric populations. The present case demonstrates the application of an integrative child-centered therapy model that combines emotional, behavioral, and unconscious work to achieve symptom remission and adaptive functioning. The aim of this study was to examine the process of an eclectic psychotherapeutic approach in the management of comorbid sleep terrors and non-organic enuresis in a child with separation anxiety features. Single case psychotherapeutic research design was used, and the study was conducted at Rimpas Special Clinic. The tools used were number cancellation tests to ascertain the attention and child behavior checklist to understand the pattern of behaviors. Ethical considerations such as anonymity and confidentiality was maintained. Informed consent was taken from parents. Verbal assent was obtained from child in the presence of parents. Let us go through the case profile. Master A. Kumar, 7-year-old only child Hindi-speaking male from Ranchi, presented with the complaints of sudden awakening from sleep, panicky scream, minimal recall of the event, nocturnal bedwetting, preoccupying worry that parents may leave. This was present since 3 months. The nature of the illness had an insidious onset, continuous course, and improved upon psychotherapy. The diagnosis given as per ICD-DCR was comorbid F51.4 sleep terrors and F98.0 non-organic enuresis with the differential diagnosis of separation anxiety disorder. The pre-intervention assessments showed the following results. On number cancellation tests, he had his attention was aroused and sustained considerably. And on child behavior checklist, he had high scores on somatic scale on a clinical level. And on anxious depression, withdrawn depressed scales, he had borderline level of scores, thus indicating that he had internalizing syndrome indicative of anxiety and somatization. This is the behavioral analysis of the chief complaints that has been categorized under excess behavior, which were nightmares, bedwetting, crying spells, and then deficit behaviors were poor recall, withdrawal after bullying, and asset behaviors were academics, good academics, plays, superhero identification. The child shows anxiety-based internalizing behaviors with physiological and social manifestations. Fantasy and scholastic motivation serve as a protective factor. Using the 4P, or given that the 5P model, now that we have also written the consequences, we have conceptualized the case as with the predisposing factors identified to be over-attachment with parents, particularly the mother, sensitive temperament, fantasy-prone personality, only child status, inconsistent availability of primary caregivers. These symptoms were precipitated by bullying and peer conflict at school, sudden emotional distress in absence of parents, transition to a new class environment. The perpetuating factors were continued bullying and teasing at school, parental unavailability during the day, reinforced dependency behaviors, self-isolation following social stress, immature emotional regulation skills, and limited recall of night terror episodes. While the protective factors that were identified for psychotherapeutic purposes was supportive and cooperative family, above average academic ability, interest in extracurricular activities, fantasy play involving superheroes, intact social interest, and therapeutic engagement. Let's go through the therapeutic process and the techniques that were used to achieve the targets. The first target was to establish a therapeutic rapport and build trust. To do so, supportive techniques and behavioral techniques were used, such as use of superhero action figures, drawing superhero play, make-believe enactments of Avengers, parental involvement in structured routines. The second target was to elicit dream content and underlying unconscious material. To do so, hypnotherapeutic hand levitation method was used. Induction through guided relaxation and visualization was used through a storytelling method. Indirect suggestion, such as visit the dreams that come at night before the occurrence of night terror, was suggested. Reduce frequency and intensity of sleep. To do so, sleep hygiene scheduling with brain night sticker charts were used. Post hypnotic suggestion, such as you are close friends with a classmate and spending happy playtime with him, was suggested. Further, to minimize the bedwetting episodes, bedwet alarms, dry night reward chart are added to the previous sticker charts, and scheduled toileting parental reinforcement was used. Further, the target of to decrease the separation anxiety symptoms, systematic exposure to parental absence, graded exposure was used, and brave movement chart was added to the previous sticker chart that was already present, which also added a contingency for parental absence. Visualization of the protective glow was used in hypnosis. To reduce the school avoidance behavior, reward for attendance, role play of classroom scenarios, thought, emotion, behavior mapping through cartoons were used. To achieve the full resolution of sleep terrors and bedwetting, fading reinforcement of schedules, reframed dream imagery upon probably as the symptoms subsided. Post hypnotic discussion was done both with the child and the parents. To enhance the self esteem and resilience to peer teasing, drawing of strong me versus sad or scared me, and storytelling with superhero narratives and role play was used. To foster age appropriate emotional regulation, emotion color coding to identify the emotions and pause and choose game relaxation breathing was used. And to generalize these coping strategies and maintain positive parental relationship, parent management training was implemented, where emotion coaching was given to both the child and parent. Structured praise and shared bedtime rituals as part of contingency was implemented. These were the management outcomes. There was complete remission of sleep terrors after 12 sessions, and nocturnal enuresis was absent. There was improved frustration tolerance and emotional vocabulary. There was a reduced separation anxiety and clinginess towards the parents. We can look at the pre and follow up assessment differences over here. On somatic scale on CBCL, the score dropped down to normal range. In all the three scales, it had gone down to normal range. On anxious depressed scale, it was 9 and it went down to 4. And on withdrawn depressed, it was borderline 4 and it went down to clear normal range. And there was enhanced self-confidence in peer relationships. He was able to maintain better relationship with his peers and interact better in his classroom settings. He maintained progress at 1 month follow-up as well. This case demonstrates the efficacy of integrative psychotherapy in childhood anxiety-related sleep and elimination disorders. Behavioral methods targeted symptoms, hypnosis resolved unconscious conflict, and play therapy improved affect regulation. Parental and school management ensured systemic reinforcement. These outcomes align with the previous studies such as Olnison, Cohen, and Gardner have used similar techniques for the management of symptoms that were presented by Master A. Kumar. In conclusion, an integrative, developmentally sensitive, and family inclusive approach combining behavioral conditioning, symbolic play, and hypnotic reframing effectively resolve both behavioral and emotional components of the disorder. There is a need for more evidence based outcome researches that shall demonstrate the technical eclecticism for such clinical presentations. These were my references. Thank you.
Thank you, Rajaram, for that brief presentation and keeping it on time. So we open the floor for any questions or clarifications from the participants. मैच फिक्सिंग की जरूरत नहीं है, कम ही लोग हैं. We can explore the scientific vigor. So feel free to ask questions so that we can have some kind of a scientific or academic exchange. सवाल नहीं है? You have a question? Okay. So, Rajaram, I have a question for you. So you have given the title of this presentation as an eclectic psychotherapeutic approach. पर वो जाते जाते कंक्लूजन में इंटीग्रेटेड बन गया.
जी सर.
क्या कह पाएंगे इसके बारे में?
सर मेन फोकस तो यहाँ पर इट वाज मोस्टली बेस्ड ऑन बिहेवियरल एंड हिप्नोटिक abilities. Although I've also used play therapy, supportive therapies, and also because of the power dynamism that was used to explain the different characters to build a sense of confidence in the child. There was not a proper full-fledged schedule of therapy for supportive play therapy that was being used over here to call it integrative itself. So since it was parts of the techniques that were implemented from other therapeutic approaches, also I've only included a part of the study, a part of the case. There was also psychoeducation done after the pre-assessments. I have not added that part of the presentation over here. So even in psychoeducation, only the didactic teaching part was done and nothing further apart. So I think instead of calling it an integrated approach, I understand your idea why you might be calling it integrated, because most of it is focused on hypnosis and behavioral techniques over here.
That's not the question. See, when we are saying that it is an integrated approach, so there should be a theoretical integration of
Right, sir.
why we are choosing a particular technique. What is the purpose of integration of different modalities of therapeutic techniques into interventions? We are not objecting or questioning any efficacy of any of these techniques. So whether it is hypnotherapy, whether it is behavior therapy, whether it is play therapy, so they have a scientific background for each of these techniques to be like established as evidence-based techniques in themselves.
Right.
So when we are taking them to make up a therapeutic package for a patient, so we should have a therapeutic integration.
Right, sir.
So based on our formulation. Okay, so for this purpose or this particular objective, I am trying to integrate this particular techniques from this particular therapeutic model. So that kind of an integration is missing.
Right, sir.
Okay, so that is something that is required. So it cannot be like you have all the masalas in your kitchen and you just randomly pick up something to cook something.
I understand, sir. I got your
Right.
point. But
So
the major motto of this particular study was to establish a process-based orientation instead of going for outcome.
yeah,
So
totally fine. See,
right, sir.
one is that since you are presenting a case study,
Right, sir.
okay, so since you are presenting a case study, outcome also becomes very much important,
Right,
not
sir.
just the process.
Of course, sir. Correct.
Okay, so the integration and the therapeutic formulation has to be established proper, and the objectives of your psychotherapy, whether it is your short-term outcomes or the long-term outcomes, has to be defined.
Right, sir.
And accordingly, what is the therapeutic element that you are going to take from the different modalities?
Right, sir.
Okay, what makes your current modality or the major modality deficit in addressing that point of element, and why you have to borrow it from the different modality?
Right, sir. Right, sir.
So that should be established.
Correct,
Okay.
sir.
So if आप अगर CBT कर रहे हैं, so CBT में ये element address नहीं होता, so इसलिए I'm taking it from the therapeutic play therapy element.
Right.
So I want to integrate.
Correct, sir.
And this is a particular element that that's a therapy need. This needs to be addressed. And if I stick to one particular module, I'll not be able to address that issue. So that's the reason I'm taking or borrowing one technique from a different therapeutic modality.
Yes.
So that kind of an establishment in the therapy formulation itself has to be established.
I'll keep that.
Otherwise, we'll have to keep it as eclectic.
Yes, sir. Yes, sir. Correct.
Okay, so we should not present the eclectic as integrated.
Correct, sir. Correct.
Okay, आपने उसको eclectic psychotherapeutic approach में present किया, you need to retain that.
Correct, sir.
When you are saying integrated, it should have that therapeutic formulation proper.
Right.
Thank you.
Thank you, sir.
All right. So Rajaram, so this is the part of your PhD work?
No, ma'am. This is just a case that was in the OPD that I attended.
All right. Okay. So since this is a single case study that you've presented, right? Can you tell me some limitations or drawbacks of this research?
Of course, ma'am. The sample size is very small and it cannot be generalized. And since it's one of the rare cases of sleep terrors with enuresis, that non-organic enuresis, it has been established after ICD-10 categorization. I thought this was a peculiar case to be presented because the integration, as sir corrected me, most of the researchers do not imply all of these therapies together. That is why I took up this one particular case study. And it had a lot of elements, ma'am, basically. That was one of the main reasons I chose this case.
Thank you. Although it's a very nice case study that you've presented.
Yes.
So thank you so much.
Thank you, ma'am.
the wonderful clinical work.
Thank you, sir.
But when we are presenting it on an academic platform, we need to align to that expectation.
Right. Right.
Thank you.
Thank you, sir.
Hello, everyone. I would now like to formally once again welcome you all here uh, to this scientific paper presentation session as part of the third International Annual Conference of Clinical Psychology Society of India. Now, I would like to introduce our chairpersons. Our first chairperson is Dr. Ritvik S. Kashyap, Assistant Professor and Clinical Psychologist at the JSS Medical College and JSS Hospital. Um, he is known for his efficiency, passion, and professionalism. His areas of interest are in personality disorders and Indian psychology, which is still indigenous to the Western world, but is a fortune of advanced knowledge and ideologies. He holds elite world record, Asian Book of Records, and Indian records, and Guinness Book of World Records for mental health promotion. He has been keen in serving his patients with zeal and humane touch, along with proficient training to many such budding psychologists. Then our second chairperson is Dr. Tarana Jain. She is currently an assistant professor at IBHAS, the MIT Institute of Behavioral uh, Human Behavior and Allied Sciences. She has completed her MPhil from IMHH Agra under the mentorship of esteemed Dr. Rakesh Kumar Jain. Further, she holds a PhD degree from Christ University, Bangalore, wherein her doctoral thesis was centered around developing a first of its kind theoretical model in the area of social anxiety among Indian young adults. Moreover, ma'am is also among the very few registered mental health yoga therapists with the Ministry of Ayush. Now we are deeply privileged to have both our respected chairpersons with us today to guide the discussion and provide their valuable insights on the research papers being presented. Now, for a few instructions, each presenter will have a total of 10 minutes, comprising 8 minutes for the presentation and 2 minutes for the discussion and Q&A. When the time is about to end, I'll give a tap, so please try and wrap it up in that time. So without further delay, let's commence it. And since the first presenter has been done, I will now invite the second presenter, Ms. Janvi Devta. Please give a round. Huge.
Thank you very much. Good morning, all. At the outset, I'm a bit wary of the presentation I'm going to make right now, especially because Dr. Ritvik just mentioned about the scientific rigor of presentations. At the outset, I must say that my presentation here is going to be slightly different because I am going to be talking about a training program that we have been implementing at our university. So I'm Dr. Janvi Devdat. I am working at the King Abdullah University of Science and Technology at Saudi Arabia. I work there as a clinical psychologist with the student counseling services. So my role primarily is clinical in nature. And along with my colleagues, Mr. Sidney Engelbrecht and Dr. Melissa Banasconi, we have devised this training program for building resilience in ethical decision-making in research. And the component that we bring to this training as psychologists is social and emotional competencies and building those competencies amongst researchers so as to facilitate better ethical decision-making and integrity in research. So that is what I'm going to be talking about and introducing to the audience here. At the outset, ethical decision-making is central to responsible research conduct. We all know that. We're all researchers and academicians here, so we know how important it is while making decisions and ethical decisions when we are doing our research. And we know that while decision-making is often considered a very rational process where you think very logically and you're only focused on facts, the truth is that there is a lot of social and emotional component that influences our decision-making process. And so during the training, what we try to do is to make our participants aware of the various cognitive, social, and emotional factors that shape ethics but are often under-addressed in traditional ethical training that we all undergo at research institutes. And our hypothesis is that adult social and emotional learning may strengthen resilience and integrity in complex research contexts. So we know decision-making is influenced by cognitive biases, negative, positive emotions, social and cultural factors, and also a lot of power dynamics that we all also experience while in our work. And so awareness of these factors, including our own personal biases and social emotional response tendencies, is very important. So a bit of context. Like I said, that this is a multicultural graduate university, which is located in Saudi Arabia. So we have students, faculty, staff from all over the world, from 119 countries, and almost that amounts to nearly 3,000 researchers, which includes faculty, research staff, postdocs, and students. So you can see that there is such a diversity of ideas, beliefs, culture that people bring to the research at the university, and all that plays an important role in how ethical judgments are made, and also the interpersonal dynamics between people and staff members. Very quickly, some of the literature that talks about the links between social and emotional competencies in ethical decision making. So emotions influence how people perceive consequences, ethical consequences, and social interactions, and this shapes our ethical choices. Research has also shown that emotional intelligence, particularly emotional expression, empathy, and emotional regulation, they all promote, when emotional intelligence is high and when these factors are taken into account, they promote balanced ethical assessments and reduce our own cognitive and moral biases. Then the role of culture in ethical decision making. We all know that culture shapes our moral values and reasoning styles. There is ethical relativism. People differ on a scale between ethical relativism, which means that they consider ethics or culture that varies from place to place, and therefore one's ethical standards might vary depending on what culture we come from, versus ethical universalism, where there is another school of thought that believes that no, ethics are universal across countries, across cultures, across societies, and that then influences the kind of reasoning style that I bring to the table. So there are these differing cultural perspectives that people bring with them. Then there's difference between Western and Eastern approaches. The Western approach is seen to be more individualistic, more analytical, more logic, fact-oriented, versus Eastern approaches that are considered more collectivistic, more holistic, where they take into account the context and not just the individual, but the context, their relationships with each other. And so they allow for a more variety and variation between ideas and approaches. Whereas in the Western thought, things are considered more black and white. There is less scope for areas of gray or the interaction between the context and the individuals and the objects that we are talking about. So all these various, this diversity leads to a lot of diversity in thinking and approaches that people bring to the table when they are doing research. And that can often lead to a lot of internal as well as interpersonal conflict. And that is what we are trying to address through this training program that we conduct for the staff at the university. So the workshop design, the program is called Building Resilience in Ethical Decision Making, and it's a 3-hour in-person workshop that is offered monthly, and it is open to the research community. So the participants always comprise of a mixed group of faculty, researchers, students, and the aim is to educate participants on, like I mentioned, the cognitive, social, and emotional factors that influence ethical decision making. The content that we focus on during our training involves, of course, we talk about research ethics, what ethics is, what research ethics is, what is the importance, research integrity and its foundation. So research integrity means that every institute has their own research policy. And so it talks about generating awareness about the research policies in your institute and how, to what extent do you adhere to those policies. For instance, different universities or different institutes might have different policies related to the use of AI in research. There are certain universities that have completely banned the use of AI in research, while there are other universities, for example, at my university, where the use of AI is not banned, but you have to use it in a conscious and ethical way, where if you're using it, you're supposed to disclose the purpose for which you have used it and not claim AI generated material as your own. So different universities across the world have different policies regarding research integrity and research ethical behavior. So we also discuss ethical lenses, the blind spots, various cognitive biases like the confirmation bias, cognitive dissonance, and we talk about emotional awareness, the emotional regulation strategies like reappraisal, the Linehan's three mind states, and how we can regulate our own emotions when we are conducting research to to promote better communication and avoid conflict. Then we have self-assessment. The different modalities are, we have self-assessments where we ask participants to complete the ethical lens inventory that gives them an idea of which quadrant they fall into, what is their ethical lens that they most frequently use. We use didactic input to talk about different emotion regulation strategies that I mentioned, assertive communication, and effective conflict resolution. And we have a lot of video demonstrations and case examples that we use from real life examples that come to the research compliance team and to us student counseling services to help them understand the different kinds of scenarios that might come up. Evaluation is based on a feedback form that is voluntary, and people fill it up on their own. So over the past 2 years, we've conducted 8 sessions with a total of 115 participants, and the feedback response rate that we've got is about 61%. Based on participant feedback, participants have found the training program very useful and have particularly found the portion on emotional and social learning very insightful, something that they have not been exposed to in their previous research journey and academics. And they've often mentioned that the workshop should be made mandatory for training at the university. So definitely the training has raised awareness of factors that shape ethical decisions, and the high intention to recommend this training to other people suggests that there is a perceived value and relevance of this training. And finally, as I mentioned earlier also, that there are definitely certain limitations in terms of for the present work in terms of we're basically using self-report feedback, and there's a lack of pre-post behavioral outcomes. So that kind of scientific rigor, I must admit, that is not there in the current study, but that is something that we have been thinking of and will be gradually incorporating into future work, where we do a more structured evaluation of the impact that this training is having. But yes, so this is some work that we've been doing, and I thought it was, especially because the theme of the conference was integrating diversity, I thought that this is a very useful way of showcasing how clinical psychology or psychological principles can be integrated into research ethics and training. So thank you for that.
Thank you, ma'am, for presenting this new model of training based on the ethical research. So, open to audience for any questions. So, over a period of time, you have conducted several sessions and several batches of such training has happened. So, as you had mentioned, so you can add a scientific research touch onto this whole process, so that we can like establish the efficacy of this training and its outcome from the scientific research point of view, so that we can promote this for elsewhere. Okay, so that many other institutions can take it forward for because duplication of work is waste of time. So you are doing a wonderful job in coming up with such kind of a training model. So if you can establish its efficacy, then many other institutions would carry this slide forward. Thank you for the presentation.
Thank you, ma'am, for your presentation. I agree with sir. What you are doing and what you have presented is really amazing, especially the different constructs that you've added in the research ethics, decision making, and specifically in our country, where according to the new education policy, now research is very important and it's highlighted at the educational institutions, higher education institutions. I think we could benefit greatly from these kind of models. So, yes, I agree with sir. If you could please add that element and then if it's available in the public domain for us to continue it further. Thank you so much, ma'am.
Thank you, Ms. Janvi. Now we'll have the next presenter, Ms. Trusha.
So request you to kindly stick with the time.
I'm pursuing my PhD from CIT Ranchi, and I'm currently also working as an assistant professor at Assistant University. My topic for today is integrative exposure response potential intervention on positive disruptive behavior in children and adolescents with OCD. This is a part of my PhD thesis. I'm just presenting the pilot version. So when we talk about OCD in adolescents, it manifests a bit differently. It is less commonly seen in girls as compared to boys, but the ratio of 1 is to 2 is 3. It is majorly comorbid with eating disorders, depression, and anxiety. Symptoms are mostly around contamination and likely to be seen after puberty. So, when I mention coercive disruptive behavior, what exactly is CDB? So, coercive disruptive behavior refers to any set of actions which are performed by the individual in any situation in which he explicitly imposes certain rules or restrictions on other individuals. So these other individuals are usually the family members. So these rules or restrictions are not engaging in any particular behavior or engaging in a particular behavior in a particular or certain way or accommodating the individual or the adolescent when he or she engages in a particular ritual. So if it is just coercion or forceful behavior, how is it exactly different from conduct disorder or conduct traits that have been in adults? So the first thing is majorly that individuals who suffer from coercive disruptive behavior are tactile sensitive. And secondly, whenever their demands are not met with, they usually react with a lot of rage and disobedience. Now, there's a very strong connection between CDB, severity of OCD, and whenever we talk about family accommodation. So, every time an individual engages in CDB behavior or coercion, the family members are likely to accommodate. Now, when the family members accommodate, it automatically leads to a decrease in the OCD rituals or the uh, the compulsions that the individual is likely to engage in, because of which the family members feel that the disorder has reduced. Similarly, because there is a decrease in the CDB behavior due to the accommodation, the severity of OCD automatically increases. A lot of research has suggested that resilience or making the adolescent more resilient has actually helped in prospectively reducing the OC symptoms in future. Recent evidences have also linked integrating third wave therapies along with ERP, which has shown encouraging evidence. The question arises as to why there is a need to integrate third wave therapies along with ERP. So, even though ERP is considered as a gold standard treatment for OCD, we still find that around 53% of adolescents show a relapse rate, and a greater number of adolescents are likely to show remission symptoms even at treatment completion. In our study, we conducted a randomized control trial to assess the efficacy of integrative exposure response prevention intervention. We compared them with the standard ERP on adolescents with OCD. Patients who visited the hospital via purposive sampling were taken and randomly distributed to one of the two groups. For our pilot version, we had IERP, that is Integrative Exposure Response Prevention with pharmacotherapy, and the other group was ERP with pharmacotherapy. So these adolescents were usually those who were diagnosed by psychiatrists on OCD and who also had, so we had certain screening measures. One of the measures was Reven's SPM, in which the adolescents had to score 25 percentile and above. In the measures that were used to assess them, we had CY box and CY box to assess the severity of OCD, course of disruptive behavior scale to assess CDB, and some of our secondary measures. So CY box and CDB were our primary measures, and resilience was measured through child and youth resilience. We also measured the distress by child and adolescent psychological distress scale, and we also had measured the OCD family functioning scale. This was the module that was adapted. So we integrated components of ACT, DBT, and compassion focused therapy. From ACT, we majorly integrated cognitive diffusion and some aspects of acceptance and commitment based change. From DBT, we majorly integrated emotional regulation and distress tolerance. And from compassion focused therapy, we integrated self compassion, that is tendency to engage in certain self-compassionate behavior towards self. For the ERP module, we had standard ERP, which was conducted on all the adolescents. This was the result. For socio-demographic data, there was no significant difference that was seen on continuous or categorical data. Even on the characteristics of the participants, age of onset illness, duration treatment, duration family history, course, comorbidity, and pharmacotherapy, there was no significant difference that was seen. On our primary measures, we majorly used repeated measures ANUVA, and on the primary measures, the participants were evaluated at 4 time points: pre-intervention, mid-intervention, post-intervention, and 1 month after the intervention. On both CY box, subscales, and the total, as well as CDB, we found a significant difference between the two groups, with the IERP group showing significant improvement as compared to the ERP group. Similarly, for the secondary measures on psychological distress, a significant difference was found on anxiety and depression, as well as decrease was found in aggression. Resilience also showed a significant difference, with the IERP group showing much better resilience as compared to the ERP group. On the family functioning scale, a majorly difference was found on social life as well as school performance at post-intervention. All the secondary measures were evaluated pre and post-intervention. So how did these integrated therapies actually help them? ACT helped the adolescents to accept the negative thoughts and not be involved with those thoughts. Research has also indicated the effectiveness of ACT with ERP, which was the reason why it was integrated. DBT helps them to become much more aware of their own emotions and help them to engage in the exposure activity. Research has suggested the benefits of ERP in distress tolerance, because of which they are able to engage in the ERP exposure. Self-compassion fosters the ability to let go of the thoughts and not feel guilty. So a lot of these adolescents were able to engage in internal dialogue post-intervention, where they were actually able to overcome their guilt because of compassion-focused therapy. Again, we have had evidences. Studies have actually shown an overall improvement of resilience, showed better resilience in adolescents who have been integrated with third wave therapies. And again, it is also seen as a protective factor. To conclude, pediatric OCD is indeed common in children and adolescents, and often it is heterogeneous. There has been a growing understanding of targeting CTB behavior along with third wave therapy. And the key mechanism is majorly focusing on enhancing resilience, which is why we focus directly on the individual rather than focusing on the OCD. The study had certain limitations. It was rated primarily by the therapist and not an independent evaluator. The program was conducted only in one hospital setting, which again questions the generalizability, and the sample size overall was less. For future directions, third wave therapies can definitely be tried in integration with ERP, which can be a promising avenue for further exploration. And again, integrating certain culture-specific norms in ERP can definitely pave the way for a comprehensive futuristic treatment. Thank you.
Open for questions.
Um, Thank you for this work, and I believe that you're doing this like a therapy format with clients. Okay, I'm just curious to know what are some of the challenges that you faced while doing therapy from the ACT perspective with this age group in particular.
Uh, so a lot of misconception that is usually seen in the Indian context is that adolescents do not have the theory of mind or the cognitive sophistication to engage in ACT. So there are therapeutic modules which focus on ACT for adolescents. Majorly, we used cognitive diffusion. So we use certain metaphors for them, or we made them engage in certain activities per se. So one of the cognitive diffusions that we actually helped them was with understanding the leaf on the lake metaphor, which actually helped them. Again, one of the adolescent had a value that she wanted to become a doctor as she grew up. So we used that. We just made a coat for her, and whenever she engaged in exposure activities, she would wear that coat and engage in exposure, which made it much more easier. So it was something which she valued, which she aspired to be, which made the committed action much more easier. So there were certain challenges in respect to certain adolescents who were very poor in insight. So psychoeducation was usually done through stories or in a PPT format, which became a bit difficult with them. So ultimately, we had to. So in my for total like complete this, we have analyzed it because we had to take certain more sessions of therapy for them. So that has been taken accordingly. Could not present it in the pilot version. Yeah.
I'm just curious, ERP generally is also associated with a major chunk of clients dropping out. Since you've included something new into the routine model in your study, did that kind of help with the dropout rates? I'm curious.
So, ERP actually is associated. So, many of these patients were actually individuals who had previous experience with therapy and had dropped out because ERP is something which goes again. So, it is not so easy to engage in ERP. So, it majorly becomes a forced technique. So, in our therapy, what we did was we started with ACT and we started with certain DBT techniques. So we taught them how to understand their own emotions. So a lot of adolescents could not even label their emotions. Fear was labeled as anger for most of the adolescents. They could not understand it was fear because of which they engaged in certain behaviors. So labeling, helping them understand their own emotions also helped a lot because they could sit in the exposure and they understood the rationale as to why this was being done. So that helped.
I firstly congratulate you for the study. Uh, can you please tell me if you have included most of the themes relating to OC?
So yeah, like I mentioned, we had a heterogeneous sample. Many of them had obsessions associated to dirt, contamination. Certain individuals had according to symmetry, and some others had so certain rigidity that things have to be a certain way. But majorly, it was associated to companion. A lot of individuals had obsessions associated to if they don't engage in a particular behavior, something bad might happen. So, associated with some family member, risk to some family member dying or being killed in a particular. So, all of these obsessions were. And naturally, we took the same approach with them, and it did show positive.
Given that ACT and diffusion has a very, you know, let us say, mellow down and passive way of telling things, and not intensive, distortion management and stuff. Uh, how exactly was it challenging for you to cater to different themes? Like, I'm really curious to understand.
from 11 to 17 because this is around the age when they have certain amount of cognitive insight. Using ACT was definitely challenging at multiple points of time because certain times the individuals did not have certain values. They did not know because they were suffering from motility for such a long time and they did not know how to go about, did not have any particular values. So then we had to create certain things and to help them understand what was important for them. So that was definitely a challenge. Some of the individuals did show a lot of aggression when we were again engaging in certain acceptance. So we help them understand how fusion works, how diffusion works. So we use the cloud metaphor, we use the leaf metaphor. Still, in certain individuals, we did find that they were very rigid, and it took us a lot of time to continuously practice the act technique. And eventually, when they came to a stance where they were ready, so exposure is not something which we can force. So certain individuals, so 13 was actually an ideal number of therapy sessions. For certain individuals, it went as good as 1 to 1.5 months as well. It was challenging, but we used techniques to help.
That's great. Congratulations to you again.
So I have a few questions. I'll just make it quick. So can you just go to the sampling criteria?
This one, sir? I did not actually put the whole criteria per se. Yeah, so this was. I can tell you. So basically, sir, it was focused sampling, but also whenever they visited the hospital, they were diagnosed by a psychiatrist. And so we used the Excel number system, and they were randomly either allotted to the IERP or the ERP group. Once they were allotted, so before.
Yeah, I want to understand the inclusion exclusion criteria.
They were very, so it had no of intervention in the past 6 months, and no brain stimulation or anything done in the past 3 months. And the important criteria was that they had no other strong comorbid illness such as psychosis or bipolar.
So, what your title of the study is about treatment resistant adolescents. How you have established a treatment resistant state in this in your criteria, sample criteria?
For adolescents who had undergone at least 3 trials of pharmacotherapy and not shown any resistance. So the Ranchi is actually a place where most individuals are not very well aware about therapeutic methods, and most of them had individuals who were undergoing pharmacotherapy, majorly SSRI, and three different types of tried pharmacotherapy which had failed, post which they had agreed to admission. So because most of them were from lower socioeconomic status, getting them admitted for a longer period of time was also difficult, which is why they agreed to admission only when the pharmacotherapy had happened.
So I can agree with you on this point, but there is also an element that when we are saying that it is a treatment resistant state, so the complexity of the psychopathology also differs. Right. It is not only about the exposure to psychotherapy. Okay, the complexity of the psychopathology itself is getting complicated. So at that juncture, we are introducing the ERP and IERP. Okay, so we have to be clear about what is the kind of what is the level of psychopathological state that we are taking it into consideration for the therapeutic element. Not a problem. So, have you involved any assessment or any questions related to feasibility, acceptability?
We had said see what the of the adolescents over time. even though officially we did not have them, we have followed them only up to 1 month, a lot of these patients came back even at third month follow-up. So we had tracked them over based on for them occupational mechanics, whether they could go back. How was their everyday schedule? That was
So, which was the statistical method that was implemented for this comparison? So, between group comparison. Yeah. Yeah. So the other one, the baseline to follow up, I mean pre to post. I stop you there. Did you use independent sample t-test? Why? What was your sample size? What was your sample size? I'm okay with repeated measures ANOVA. I'm asking you what independent sample did. Not this table, the other table. The other table.
Yeah, sir. The data we did. This could have gone better with non-parametric, but the sample did show some amount of overgenetic. So, yeah. A non-parametric would have been a better source, I agree, sir.
Thank you.
Thank you, sir.
All right, Trisha. Trisha. Thank you so much for your presentation. And as you have already ignited a very nice, wonderful discussion, and Sir has already given an amazing feedback, uh, I really appreciate the way you have presented and the way you've answered. Just one slight observation. Since you have mentioned that the sample is purposive in nature, yes, yeah. So it's always a good because you're already mentioning the methodology aspect, which is method now, right? So it's always a good idea to mention to have a separate slide on the sample characteristics of the sample inclusion exclusion because when you're verbally saying, it's a little difficult to register it, right? And also, as Sir rightly said, it's also better to have one diagram or something showing the research design, right? Yes. So otherwise, good job. Thank you.
Thank you, Ms. Trisha. Now I'll invite Ms. Jagriti and Ms. Ayushi for the next presentation. For Ms. Jagriti for the next presentation.
There are two presenters. Okay.
Right, so it's just Ms. Jagriti.
Okay. Please keep it on time.
Good morning, everyone. My name is Jagriti Khurana, and I'm in PsyD third year from Amity University, Noida. Today, I'm going to present on a psychological profile series on agoraphobia using the TAT and TCI, exploring the role of loss. So, as we all know, that agoraphobia lies in the anxiety spectrum and it is defined as a persistent fear and anxiety of situations where escape is difficult or help might not be available,
in situations where there is panic like symptoms or some embarrassing situation. And both DSM-5 TR and ICD-10 classify agoraphobia as a significant fear and anxiety of two or more of the following situations like public transportations, open spaces, enclosed spaces, standing in a line, being in the crowd, or being outside the home alone. It lasts for 6 months and it causes immense distress to the person, which also results in being homebound. And avoidance becomes the key feature of this disorder, which also tends to maintain the symptoms. The data from NMHS 2015 to 16 suggests the prevalence of agoraphobia in India to be 1.6%, making it a common anxiety spectrum disorder. It is also important to understand the link between agoraphobia and grief because research has consistently shown that agoraphobia is not just limited to the biological or temperament aspects but also is related to deep rooted psychosocial experiences. For example, trauma, loss, unmourned grief, unmet emotional needs, they all contribute to uh, the factors to the avoidance that the agoraphobia has. Agoraphobic avoidance is also there of the particular situations which usually stem from the separation trauma, unaddressed grief, severe relational loss, and thus avoidance becomes a protective mechanism in cases of avoidance. Because if we expose ourselves as a patient with agoraphobia, if the patient exposes himself to these situations with which he fears, then there will be overwhelming anxiety and overwhelming emotions. So, avoidance becomes the protective mechanisms there. If you also look into the personality factors, researchers has shown that there is high harm avoidance and low self-directedness, which means that the patients tend to worry excessively and they're unable to regulate their emotions or cope or make independent decisions. And thus, agoraphobia is not just limited to the fear of places, but also difficulties in coping, psychological maturity, and also safety in their relationships. These are certain literature reviews. So, a study conducted by Yates in 2018 linked agoraphobia with unresolved grief and found that there is persistent emptiness even after the symptom remission, which acts as a defense against the mourning traumatic losses. Mochkovich in 2015 also indicated that there is high harm avoidance and low self directedness and cooperativeness on TCI profile, which also tends to improve with treatment. Along with this, Easy et al. In 2014 indicated that agoraphobia severity has a positive correlation with temperament dimensions of novelty seeking, harm avoidance, and character dimensions of self transcendence. This is a case series which aims to investigate the shared themes and temperament among the three patients diagnosed with agoraphobia with panic disorder following the grief experience using TAT and TCI. The objective was to understand how grief related experiences, needs, conflicts contribute to the manifestation and the maintenance of agoraphobic symptoms. So, the patients, three adult male patients, were selected from a clinical setting who were undergoing treatment for agoraphobia with panic disorder. There was case 1, 2, and 3 with ages 21, 34, and 39. The stressors included brother's suicide, father's sudden death, and divorce due to the marital conflict, and certain avoidance focuses and the fears involved in closed spaces, crowded spaces, fear of suffocation and nausea, driving in bad weather, lifts, enclosed spaces, darkness, driving alone, crowded places, fear of heart attack, or no hospital access. Temperament and character inventory by Cloninger was used, which is a self report inventory that assesses the stable and heritable temperament traits and learned character traits, which has 7 dimensions and 240 true and false items. The temperament dimensions include harm avoidance, novelty seeking, reward dependence, and persistence, whereas the character dimensions involve self directedness, cooperativeness, and self transcendence. Thematic apperception test was used, which is a projective assessment designed to uncover the unconscious motives, needs, conflicts by analyzing the narratives that were presented by the patients on the stories. The TCA findings across the three cases include high harm avoidance, high reward dependence, low persistence, and low self directedness.
So, which means that high harm avoidance indicates that the patient tend to worry a lot, have doubtful temperament. They tend to take tensions in response to uncertain situations. They tend to be unassertive in social situations and usually anticipate harm and failure in various situations because of which they tend to avoid. There is also high reward dependence, which means that are dependency needs. There is a tendency to be sentimental, emotionally attached, and dependent on others. Low persistence means which the patient has a tendency to be inactive, indolent, and they give up easily. They do not persist on the goals, the tasks that they have. Low self-directedness reflects a tendency to be immature or display weakness when they are not guided by a mature leader. So they are unable to have goal-directed actions or guide themselves through the various situations. This I have tried to propose a model from TAT that the environment was seen as aggressive, demanding, deprived, and controlling, which resulted in an insecure self, also perceived as ambivalent, inadequate, dependent, and helpless, which give rise to primary needs of succurrence and affiliation, conflicting with the needs of rejection, resulting in fear of loss of love and fear of rejection, which was catered to by using the defense mechanisms of wish fulfillment and rationalization. The secondary needs included the passivity, conflicting with activity, nurturance conflicting with succurrence, aggression conflicting with superego, and abasement conflicting with autonomy, which resulted in anxieties like fear of failure, fear of rejection, fear of loss of love, fear of abandonment, and fear of failure. The defense mechanisms used were wish fulfillment, displacement, and rationalization. So, in discussion, we can say that grief, trauma, personality vulnerability, they all interact to create a psychological environment that makes it difficult for the patient to face their fears. The avoidance becomes their safe place, and exposure becomes a threatening situation. The world outside becomes associated with the threat rather than security and safety. So, grief might have intensified these inclinations, turning fear of rejection, abandonment, dependence into avoiding circumstances that represent exposure or separation, indicating agoraphobic avoidance. So here I have tried to make a graphical representation of a mechanism of maintenance. So deprived environment and helpless self. The perceived environment as deprived and controlling exacerbates the low self-directedness, which results in weak internal guidance system and dependence on others for stability. So they have weaker self-confidence and sense of control, because of which they look to others for support and safety. This manifests as avoidance behaviors and fear of abandonment, which becomes central, thus maintaining the psychopathology. So, the clinical implications suggest that the treatment must address the character deficits and the unresolved psychological themes, focusing more on the grief processing rather than just exposure. Should focus on resolving the conflicts between the needs for dependency and the fear of rejection. The future research can also investigate the impact of therapeutic interventions, specifically targeting grief process and character maturity on long term remission of agoraphobia. Thank you.
Open for questions. So if there are no questions, I congratulate Jagrati Khurana for this wonderful study. So I just need a clarification regarding the method of analysis of which is the qualitative analysis method that you have incorporated in your study.
So basically, thematically, I have tried to understand the themes that have come from the narratives of the patient provided on the stories. Finding all the common themes from the three patients, and then looking for the common aspects of themes, needs, and conflicts.
So is it according to thematic analysis?
Statistical analysis has not been used,
No.
but
Qualitative analysis I'm talking.
no, sir.
Okay. So yeah, we have not incorporated standard measures
No,
of
we are not
qualitative analysis.
All right. Thank you, Jagrati. That's a nice presentation. So since you said it has got clinical implications, right? That one can focus on grief.
Grief processing.
Grief
yes.
processes when dealing with agoraphobia, right? Can you tell me which treatment could you incorporate then? Because the research indications said that we could have some therapeutic interventions. So, which
Yes.
treatment would you recommend?
Right. So we can start with the grief processing, the grief therapy that is there, using various techniques that are there. For example, letter writing, or uh, maybe reminiscing of the memories that they have, making a new relationship with the deceased one. So working on the grief aspects will be there, providing the safety and security to the patient first. And then we can move towards ACT, and maybe some parts of third wave, maybe DBT, emotional processing. And I think we can also use some aspects of CBT if there are cognitive distortions that are there, but mostly focusing on grief and grief therapy and ACT.
All right. Thank you so much, Jagriti, for your presentation.
Thank you, ma'am. Thank you, sir.
Thank you, Ms. Jagriti. With that, we come to the end of the paper presentations for this session. I would like to express a heartfelt gratitude to our respected chairpersons, Dr. Ritvik Kashyap and Dr. Tarana Jain, for their time, guidance, and insightful feedback. A sincere thank you to all our presenters for their hard work and valuable contribution, and to our audience for their attention and engagement. I now request Ms. Ria to please felicitate our chairpersons.
You can take that as a background. Yeah.
We now have a plenary session by Dr. Debbie Ellis in the F2 auditorium. We can all proceed for that. Thank you, everyone.
हमने टॉपिक ही वो चूज किया नहीं नहीं पूछना क्या है इसमें पूछना कुछ लायक टॉपिक नहीं है ये एक होता है लायक टॉपिक ठीक है मुझे तो और भी नहीं फर्क पड़ता है आई विश ये वाला है नेक्स्ट तुम
ठीक है, अभी टाइम है, तब तक मेरा ही है ना, पर यहाँ बैठना होगा। हाँ अभी तो अरे हम लोग की तो वोटिंग नहीं लगे, पर ठीक है, सही है, नहीं चाहिए हमारे घर की शादी है। फ्लाइट भी मुझे मूव करना है ना, करो। अरे इसको चेयरपर्सन ही है। हाँ बोलो ना। हाँ सुरेश सर को, हाँ मैंने कॉल करा, नहीं उठाया। ले आओ, बाहर ही है, तो एक ले आओ। सुरेश चेयरपर्सन। हाँ मैंने करा अभी कॉल, फिर बाहर, वो एक्चुअली बाहर ही है, हम मिले हैं, एक कोई चले जाओ और ले आओ। वो परफेक्ट है। प्रिया मैम, कंफ्यूज हो जाओगे, आई नो। अरे भाई ये एक बारी कट गया ना, इसने क्रॉस दबा दिया, खत्म कहानी। इसको खोलने में 15 मिनट लगेगा कम से कम, 15 मिनट नहीं, मतलब वही 5-10 मिनट, मतलब तुम देर का 15 मिनट जैसे दिखेगा। मैंने इसको बड़ा कर रखा है, ठीक है ठीक है। हाँ और तुम सिर्फ 2 उंगली से ऐसे ऐसे करोगे, ठीक है। नहीं ये तो पता है। हाँ बस सब देखना ही है मुझे, ऑडियंस में। सीटीएसआई का मीटिंग है 5 बजे। नहीं सीटीएसआई मेंबर, मैं भी सीटीएसआई मेंबर हूँ। 6,000 पेमेंट है, तुम भी कर सकते। बेनिफिट कुछ नहीं है, लाइफ टाइम जैसे आईएससीपी का जिन्होंने लिया हुआ है उनका वही रहता है कि तुम मेंबर हो, क्या चल रहा है दुनिया में, ये सब तुम अपने नाम के नीचे फेलो मेंबर ऑफ सीटीएसआई फेलो मेंबर लिख सकते हैं। तो लेना चाहिए, तो वो 6,000 ईयरली नहीं, लाइफ टाइम सभी, इसलिए मैंने लिया है। हाँ, मैंने अभी 2 मंथ्स बैक मैंने ज्वाइन करने के बाद, हालांकि मेरे पीछे बहुत लोग पड़े हुए थे जिसमें से क्यों नहीं देती है, फिर मैंने लिया, फिर तुम कैसे मिलता है, ठीक है। और इनकी मतलब लेट्स सपोज के आगे जाके बिकम्स अ गुड वो, फिर तुमको कुछ बेनिफिट तो मिलेगा, सोचो कि तुम लंबे टाइम तक उसमें तुम कंट्रीब्यूट कर रहे टाइम पे तुम भी और से फिर नहीं है ये सारे उसके बॉडी के साथ, एक किसी बॉडी के साथ वो रहना चाहिए। फिर मेरा पहले था कि आईसीपी के साथ होगा, स्टूडेंट में थोड़ा सस्ता पड़ रहा था 2,500, फिर आईसीपी तो डिजॉल्व हो गया करके फिर मैं नहीं गया। ठीक है अभी के लिए जो है तो ठीक है। तुम साइकेट्रिक वाले में भी जा सकते हो, उसकी भी ना क्राइटेरिया होता है, क्राइटेरिया के बेसिस पे जाना। गुड आफ्टरनून हो गया ना,
मॉर्निंग तो खत्म हो
मतलब
गई।
हाँ हाँ पीपीटी तो इसने पब्लिश कर दिया था, आप करेंगे। आफ्टरनून हो गया ना, for emotion which is known as this intervention was jointly developed by WHO. तुम अक्सर देखोगे मैं अभी कर रहा हूँ ना, ये भी सोचना है कि हाँ ये मुझे बड़ा भी होता है तब भी हाँ हाँ वो कर सकते हैं जैसे एमडीपी के जैसे नाम वो तरीके ज्यादा डीप में हो जाती है बीमारी अभी वो है ना उनसे हम अरे सुरेश सर को बुलाया था, गए अच्छा गए भाई मैं खुद से घूम से ठीक कर रहा हूँ। मैं थोड़ा थोड़ा ही कवर कर दी हूँ फिर मैम, ये देख लो आपको इसमें नहीं था ये तो मैं डाल दूंगी। ये ई से डॉलर सेशन क्या क्या कंसिस्ट करना है, ठीक है, और केयर गिवर है। मैं क्या बोल रही हूँ मुझे खुद ही नहीं पता। बेसिक हेल्पिंग स्किल्स नहीं, बेसिक बहुत सारी चीजें हैं, बेसिक हेल्पिंग, एम्पैथी, कम्युनिकेशन, कल्चरल, ग्रुप मैनेजमेंट। अच्छा तो ये किसका है फिर ये टॉपिक, किसका कौन सा वाला? ये मैम का है निष्ठा मैम। अरे निष्ठा मैम आपका तो तो फिर मैं हटा रही हूँ मैम। हाँ आप हाँ इसमें से देख ले। स्लाइड्स तो वैसे ही है, जब मैं इंट्रो प्रिपेयर कर रही थी ना तो इंट्रोडक्शन में भी थोड़ा बताया था उस सेशन के बारे में। आई थिंक मेरा 15-20 मिनट इधर
Hello. Good afternoon, everyone, and a very warm welcome to all present here. We are delighted to have you all with us for the symposium titled Group Intervention for Adolescents in Adversity Affected Communities Using Early Adolescent Skills for Emotion. The theme highlights the need for early skill based emotional intervention to support adolescents facing adversity, reflecting a growing commitment to preventative and community centered mental health care. It is my absolute honor to introduce the esteemed chairperson for for this session, Dr. N. Suresh Kumar Sir, Assistant Professor and Clinical Psychologist in the Department of Psychiatry at Madurai Medical College. Dr. Kumar holds an MPhil in Clinical Psychology from Sri Ramakrishna Institute of Higher Education and Research, Chennai, and a PhD in Neuropsychology. He has extensive experience in clinical neuropsychology, psychological assessment, learning disability remediation, and behavior therapy, along with strong commitment to innovative research in clinical psychology. Sir has also contributed actively to the professional community. He serves as the General Secretary of the Clinical Psychology Society of India and is an important member of the Tamil Nadu Association of Clinical Psychologists. We would like you to invite you on the stage, please. We are privileged to have with us a panel of insightful speakers who will be sharing their perspectives on this vital theme. Please join me in welcoming the speakers, Dr. Nishtha Kumar ma'am, Miss Prableen Kaur Chawla ma'am, Miss Ria Mahanti ma'am, and Miss Muskan Marwa ma'am, who will together discuss and share insights on strengthening emotional well-being and resilience among adolescents navigating adversity.
Good afternoon, everyone. Today, I will be speaking on the introduction for early adolescent skills for emotion, which is known as EASE. This intervention was jointly developed by the WHO and UNICEF, published in 2023 as a part of WHO series on low intensity psychological interventions. Today, I'll discuss the background, design, structure, and early implementation principles of EASE, covering the content of the manual. Now I will be speaking on the context and rationale for ease. Adolescence is a unique and sensitive developmental period. It is a bridge between childhood and adulthood, a stage marked by rapid biological changes, shifting identity, new social roles, and evolving cognitive capabilities. During this phase, experiences of adversity have particularly powerful and long lasting effects. Across the world, millions of adolescents are exposed to adverse conditions, chronic poverty, displacement, humanitarian emergencies, and community violence. These exposure elevates the risk of emotional and behavioral problems such as depression, anxiety, and stress. However, most adolescents who struggle in this way never receive evidence based psychological care. Services for children and adolescents are scarce in many countries, and even where they exist, barriers such as cost, stigma, distance, and shortage of trained professionals make access difficult. The preface of the manual covers this as a global equity issue. While mental health problems occur everywhere, The gap between the need and service access is widest for adolescents in low and middle economic countries, the very settings where most of the world young people live. Recognizing this unmet need, WHO and UNICEF designed EASE to fill the service gap, creating a low-intensity, scalable intervention that can be delivered safely by trained non-specialists under supervision. In this sense, EASE aligns with the WHO's stepped care approach, offering focused, non-specialized psychological support that sits between basic psychosocial help and clinical treatment. Now, the overview of EASE and its core skills. EASE is a brief group intervention that combines 7 sessions for adolescents with 3 sessions for their caregivers. It teaches 4 foundational psychological skills that cut across proven therapies for emotional disorders. These skills are, the first one is identifying feelings, developing emotional awareness and vocabulary. Then we have stress management, learning to calm the body and regulate physiological arousal. Then we have behavioral activation, engaging in pleasant and meaningful activities to lift mood, and problem solving. Together, these skills help adolescents understand, manage, and act on their emotions in adaptive ways. The caregiver component ensures that supportive adults reinforce their skills at home, creating a more sustainable environment for emotional growth. EASE can be implemented in multiple settings, such as schools, youth clubs, community centers, or health facilities, ideally where adolescents already gather and where referral pathways to protection or clinical services exist. Now, who is the manual for and its structure? The manual is written primarily for helpers, but also for trainers, supervisors, and program managers. Helper is a term for the person delivering EASE, someone who may or may not be a trained mental health professional. The manual itself has 3 parts. Part A is essential information, which includes guidance on preparation, training, supervision, inclusion criteria, and ethics. The part B, that is intervention, which includes detailed step-by-step instruction for the 7 adolescent sessions and 3 caregiver sessions, complete with scripts, timing, and activity descriptions. And the last is the annexures, which provide practical supplements, managing safety issues, games and activities, home practice hints, and session summaries. Now, who is the EASE for? EASE specially targets adolescents, which is age 10 to 15 years, who experiences emotional distress linked to adversity. The program supports those whose symptoms interfere with their daily functioning, but who do not require intensive clinical treatment. There are explicit exclusion criteria that includes adolescents at imminent risk of self-harm or suicide, those showing severe disruptive or aggressive behavior that would compromise group safety, and those with severe mental, neurological, or substance use disorders such as psychosis or severe intellectual disability. Adolescents with acute protection risk, for example, ongoing family violence, must first be referred for specialized child protection services and reassessed before joining EASE. Reasonable accommodation should be made for participants with disabilities where safety and communication permit, ideally in consultation with specialists. Now, what is the preparation that is done before running EASE? Before launching a EASE group, several preparatory steps are mandatory. First is selecting and training helpers, trainers, and supervisors, ensuring competency through both classroom and field training. Establishing a referral pathway to child protection, social services, and health facilities so that any case involving safety risk can be immediately managed. Then we have secure organizational resources for follow-up on high-risk cases and to confirm the availability of health and social care partners for participants who require additional or specialized support. Now, the training and supervision of helpers. Training is a backbone of the EASE model. For non-specialized helpers, at least 80 hours of classroom training, typically for 10 days, is required, facilitated by mental health professionals competent in all EASE skills. The curriculum covers basic understanding of depression, anxiety, and stress, learning and practicing basic helping skills, understanding the rationale and steps of each skill, role plays and demonstration, managing common delivery challenges, self-care and boundary management, and competency assessment. Following classroom work, helpers must complete in-field practice, delivering at least 2 supervised practice groups. This phase turns theoretical knowledge into practical skills. Next, we will be talking about implementation settings and practical consideration. EASE can operate in community, educational, protection, or health setting. The manual highlights several key considerations. The first is accessibility and safety. Choose locations that are easy and safe for adolescents and caregivers to reach. Physical space, ensuring enough room for all participants to sit comfortably and move during activities. Privacy, session must be shielded from outsiders to maintain confidentiality. Then we have stigma management, present EASE as a skills building or emotional well-being program to reduce labeling. School context, when run in schools, teachers should not act as EASE helpers to preserve role boundaries. School counselors or other staffs are better suited. Legal and ethical issues, understanding local laws for reporting suicide risk or family violence, and map out available service for immediate referral. There are some cultural and contextual adaptation also. EASE is designed as a generic global applicable model, so contextual adaptation is expected. Adaptation, however, must focus on how the material is delivered, not what is delivered. The core therapeutic skills must remain intact. The common adaptation areas that are included in the manual includes language, translating key scripts and examples into local languages and idioms of distress. Then we have cultural references, adjusting names, images, or daily activities in the material. Gender and age appropriateness, tailoring examples for younger versus older adolescents, and also session scheduling, modifying frequency or combining caregiver sessions into a single workshop where attendance is difficult. A good example of adaptation comes from the e-storybook, which follows a character named Kian, and the programs may change Kian name, appearance, or hobbies to make the story relatable, but the purpose of each story segment, teaching a specific skill, must stay unchanged. Adaptation should always involve mental health professionals familiar with the context and community stakeholders, ensuring cultural relevance and local ownership. Now, what are the practical materials and resources included in this manual? We have e-storybook, read aloud by helpers in adolescent sessions. There is EASE workbook, one per adolescents for exercises and home practices. There are posters, large visual aids for key components which are displayed during the sessions. There is caregiver handouts, which is take-home summaries of the main messages, and also basic supplies such as paper, pens, and safe storage for confidential materials. Confidentiality is emphasized. All participants' workbooks and assessment must be securely stored, maintaining privacy and data protection. Now, what are the key ethical principles and safeties? So it underlies some ethics that are confidentiality within all group, informed consent and voluntary participation, immediate referrals for any disclosure of self-harm, abuse, or risk, and supervisor support for helpers managing such situations. Now, in summary, the Early Adolescent Skill for Emotion program provides an evidence-based practical framework to promote emotional resilience among adolescents facing adversity. It is a brief, structured, cultural, adaptable, and designed for delivery by trained community helpers under supervision. Now, I would like to call upon my colleague, next speaker, that is Ms. Riya Mahanti, to continue with the symposium. Thank you.
Thank you, Muskan, for introducing me. So before starting ahead, I would again like to introduce you to the topic of ease. The full form is Early Adolescent Skills for Emotions, ease. It is basically applied onto the adolescents age range of 10 to 15-year-olds only. And it is where the children are facing adversities like any kind of trauma or flood situations, environmental adversities. Okay. So, starting off, my topic will start off from the basic helping skills and its foundations. So, in the EASE program, our greatest tool aren't that complex. It's the basic thing, the basic helping skills in any of the mental health professionals that is the basic skills, that is empathy. Yeah. So, the first foundation as an empathetic listener is the confidentiality. So, the first foundation is confidentiality. What's shared in the group stays in the group. So, this creates a safe space where the participants can speak, especially they are very, very, very young. So, which is why we, as the mental health professional, needs to ensure in that closed space that this information that you share among the people around are not going to be outside there of the room. Okay. So we remind them that if someone is in danger of being harmed or harming themselves or anything that is happening, we must act to keep them safe and involved by our supervisors. So next is empathy, which is the starting foundation or the communicating concern. So empathy means truly means listening and showing understanding. We don't have to fix the problem basically here. So just being present and saying that that must have been hard for you. The basic statement that must have been hard for you is enough. So we also take care of ourselves and reach out for support if we feel overwhelmed. The non-verbal communication here also matters the most. A warm tone, open posture of the mental health professional who is delivering the program of ease, and the gentle nods that shows that yes, you are listening. If I here stand and just deliver the whole thing with a straight glance, that will be very boring. So with that soft tone, with that soft tone and your gesture, that is mandatory to be balanced out in that session when you are carrying this ease program. Another key skill is validation. Helping participants, those are the young adolescents, see that their feelings are normal responses to difficult experiences. When they realize that the other feel the same way, then they feel less alone. Oh, that this thing happens with the other person as well. Oh, this is normal to feel like that. So that is when the other adolescents will also try to open up. Okay, so we also must set aside our personal judgments. Every participants deserve respect, and even if their beliefs or behaviors differ from ours or the background that the mental health professional is coming from, a non-judgmental space helps the adolescents feel safe and open to learn. Finally, we avoid giving direct advices. This is the important point that has to be noted. Instead of telling participants what to do, we guide them to find their own answers by asking thoughtful questions like, what do you think might help you here? So it helps the mental health professional to understand that child better, that what he or she is seeking in this closed space. In the end, helping is not about doing more, it's about being more present, patient, and compassionate. Also, here I would like to tell the audience that in this PPT, in my PPT slides, most of the things that I'm going to share here are not present here. So basically, I would like you to listen to me in a very attentive manner. Okay, so proceeding ahead with the next topic, that is the power of empathy and communication in this EASE program. So one of the powerful tool is not our knowledge, it's our training and even our experiences that we gain over the time in this field. So it is our ability to communicate with empathy, and empathy is again the foundation which I have already said in the first slide. So, moving ahead, when a participant shares something painful, our first instinct might not be to fix them, but in ease, our goal is not to solve, it is to support. It is not to solve, it is only to support. These simple, sincere statements communicate compassion without the judgment, and that does the work. So they let the participant, especially the mental health professionals who are delivering this ease program, they basically deliver this moment. They deliver the participants that they know that they are not alone and their emotions make sense. Sometimes all a person needs is to feel heard before they can begin to heal. However, empathy also requires balance. We must stay emotionally present without becoming overwhelmed. Hearing painful stories can touch us deeply, but it's important to maintain our own stability. If we carry the emotions of the others too easily or too heavily, we might risk ourselves onto the burnout. So it is important to take care of that as well. Finally, the true empathy means accepting the differences. This is the main thing which the EASE program is delivering. So basically, the EASE programs are delivered by the social workers, the people who are just passed out from their bachelor's or master's in the counseling or any other field of psychology, of the other domains. It is so, which is why this program is that easy for, or this manual, which is there shared in the WHO and the UNICEF websites, which is very easily understandable by them and easily deliverable. So, through our words, our tone, and our presence, we have the power to help the adolescents and the caregivers feel understood, respected, and empowered. Going ahead with the cultural sensitivity and inclusion. So in the EASE program, every adolescent and caregiver we work comes from a unique cultural, linguistics, and social background. So which is why in the previous slide that I have talked about, that we have to lower our judgments in that scenario. Cultural sensitivity means recognizing and honoring the differences. So in beliefs, traditions, and languages and emotional expressions, it is about being curious, non-judgmental, open, not assuming that, oh, this person is belonging from such a strata or something, the background, and might be that they are like that. So it is not advisable in the program of ease. We may not share our participants' experiences, but we can always show genuine respect for their perspective that they are going through. At the same time, inclusion means ensuring that every voice is heard in the space that they are there. There may be moments when we encounter beliefs or practices that could cause harm. In those cases, we respond with care, not confrontation. That, oh, that you are going through such trauma. That need not to be addressed then and there in that group. Our tone, patience, and respect often speak louder than our words. So when we lead with empathy, fairness, and respect, we model inclusions for the entire group. We teach by example that every person, regardless of the gender, background, and belief, deserves to be treated with dignity. Going ahead, the group management techniques in the EASE program. So managing a group effectively is one of the most important skills that is there in the EASE manual. Good group management starts with preparation. So before each session, the mental health professionals here plan a space, the chairs arranged in the circle or the semicircle way, distractions needs to be removed, materials needs to be there on their spaces. We encourage participants set clear rules from the start and remind everyone that the respect and confidentialities are essential. Even if, let's suppose, two people, let's suppose that a person shared something, the other adolescent, because they are just in the range of 10 to 15-year-old, they need to respect that information need not to be there outside the room. When the challenges arises, we stay calm as the whosoever is delivering the ease model. If a participant disrupts the group, we address it respectfully, not with punishment, but with reflection. We might say, let's focus on what we are learning together and speak privately after the session to that child if needful. Going ahead with the managing challenging situations. So in every ease group, challenges will arise because they are coming out of their adversities. So adolescents and caregivers come with different personalities, emotions, and experiences. Our role as helpers is to stay calm, compassionate, and confident even when things get difficult. Sometimes participants share very personal and sensitive informations and experiences. So at that time, we need to thank them that they truly trust this space to share that information. And after that, after that we need to deliver it like this, that we think that it is sounding so important. Let's talk more about this after the session, so that child comes to you and share their personal experiences. If a participant ever discloses abuse, neglect, and thoughts of self-harm, we must act immediately but carefully. We reassure them that that they did the right thing by sharing it to us, and explain that we will speak to our supervisors, because again that I have said that these are run by the professionals who are not qualified onto the higher ranges. So we also manage group tensions like teasing, arguments, and cliches by promoting inclusions. In short, managing challenging situation is not about the control; it's about the care. Okay. So moving ahead, Ms. Pravleen Kaur Chawla is going to take over the assessment part of the EASE program.
First of all, I would like to thank Riya ma'am for calling me on the stage and introducing me. But nonetheless, I would introduce myself again. My name is Prableen Kaur Chawla, and I am a clinical psychologist as well as an assistant professor in the Amity University. So the topic that I will be covering for is going to be on assessments. Right. So let's make it a little more interactive. I guess the session is becoming a little maybe quietened and boring. Okay, all of you are assuming are in the fraternity of clinical psychology. Why is an assessment necessary for any kind of intervention that we come across? I'm very sure ma'am has given ample amount of emphasis on the fact that this intervention has been given by the WHO and UNESCO, and it is very essential to the class of children who are suffering from adverse situations. So why is assessment important? What could be the reason in such case if we talk about it? I would like any kind of answer. Yeah, please. Yes. When we are talking of such adverse situation, the thing is that it is not only the situation that is causing an emotional problem per se, but this manual that we had come across is actually tapping upon the cognition, the social, and various other aspects, where they are suffering from it, right? So, as we all know that this has been jointly developed by the WHO and UNESCO, what they are saying is that to tap upon all these aspects, they want to go through an assessment. Now assessment is not just a place where you're trying to take in a data or an information. It is more of a dialogue between the person who is taking the information and one who has suffered. So it is not just a data, but it is done on the humanitarian grounds, right? So that is why the assessment becomes very essential here. Now for the smoother going off the assessment, yeah, it has been divided into two sessions. The one is pre-intervention assessment and the one is post-intervention. So now when we are talking of pre-intervention session, what we had come across is that they had divided it into 5 different steps. Now the first step is introduction and consent to participate in the assessment. Now, anywhere that we go, even in a very normal clinical setup, not just the adverse ones, we have seen that we are taking the case history. Whenever the client is coming in,
with the caregiver, in fact, also we are asking the client that are they willing to consent and give further information or not. So the same thing is happening here as well, right? Now, when we move forward to the consent and their introduction part, the introduction part over here basically focuses more on the demographic details, of course. But other than that, what they are focusing on is the family history that they want to give emphasis to, because sometimes when we are talking of adverse situation like these, the family can be one of the reasons for such situations as well. It is not just flood and environmental aspect and various other things, but it could be a domestic abuse if we think of it, right? So that is why they want to focus on the family history, as well as what they want to focus on is the treatment part of it, whether they had gone through a treatment beforehand also or not, or if they are ongoing with some anatomical medical treatment, right? So that is why they want to give very larger chunk of focus on the introduction and consent to the participation. The next one is question for the adolescents. Now, once the consent has been given and the information has been obtained, there are certain questions that they want to ask the adolescents. Now, these questions pertain to very many things. For example, they want to see if they have internalized their disorder or whatever issues they have had. So, what is the intensity of this? They would want to measure it. So to measure it, they usually use a checklist which is also known as pediatric symptom checklist, right? So if you go through the manual, you will come across very many tests like these where they're trying to measure certain things beforehand so that they can move forward with the intervention part. Intervention part will be taken by later. So there is that. Apart from that, what they are doing is they are also assessing the imminent risk of suicidability or self-harm. Now, when we are talking of imminent risk, what could be the possible questions you ask your clients when you see them during the sessions or your training time? If they are at all, prone to causing self-harm to themselves, or maybe are suicidal in their nature. What could that be? What are certain questions? Maybe your top three questions that you would ask? And you can always involve the caregiver. Please go ahead. You want to answer, I think. Right. Okay. So basically, what you want to focus here on is ki from how long they have been thinking of harming themselves. What are the methods or means they have used to harm themselves? And the main question is what has triggered them to harm themselves? Because here we are definitely again focusing on the adverse conditions that cause the emotional unease. So that those three questions are very important if I talk in context to the ease manual, right? Now there are also indications of immediate risk of suicidability and self harm as well. So there is a difference between the immediate and imminent risk, right? So imminent is basically as of now, very shorter period of time, and the immediate is more little prolonged in its nature, could be let's say 6 months. So there is a difference of questions which you can find in the manual, but this is how these three indicators are taken care of. Apart from that, what they have added is in the question part for the adolescents especially is the evaluation of the intervention, which basically means the feedback. Now once the information is taken, of course we are focusing on the feedback part of it, whether they liked what has been asked, or whether they disliked something, or whether they would want to change something, or maybe there could be a situation wherein they will say that they had given so much of information that they might want to drop off from the intervention altogether. So there are very many situations like these that can occur. So you have to do what the client wants from you, because definitely it's a sort of a universal rule that you cannot force them into it, right? The last part of the questions for the adolescent step is end assessment with adolescent.
So when you are talking of ending an assessment, of course, you are still thanking them. Whether they consent to it or not, or maybe drop in the middle, the thanks has to be given to them, right? Now, the next step or the third step is questions for the caregiver. So, like ma'am has also told earlier to you guys that the adolescents are definitely involved in it, but there are caregivers also along with them who are equally involved in this session or in this intervention. So a couple of things to keep in mind when you are questioning the caregiver is first of all you need to measure their emotional distress. Now when we are talking of caregiver and we try to understand from their lens, what we are trying to do is that they have been seeing their child, adolescent child, so to speak, that they have been internalizing their issues and they have had certain kind of distress. What, how are they able to see it and what they are doing about it, but of still feeling helpless? So that is something that you need to tap upon and measure. Other than that, what you need to measure is the measure of caregiver report on child internalizing problem. Now, when the child is internalizing the problem, how they are perceiving it is something that you sort of focus on this step. The third step is evaluation of the internalization. And the last one is end of assessment with the caregiver as well. Again, when we are ending any session, we need to thank them whatsoever. The last step for the pre-intervention is your, again, summary and the feedback. Now we are coming to your post-intervention. I'm really sorry I did not change my slide. You can give it a read if you want to. This is for the pre-intervention assessment. And this one is for the post-intervention assessment. Now, when we are talking of post-intervention assessment, what we are doing is that we have completed various modules and interventions used in the ease, which will be talked later by ma'am. But what has to be taken care of is when you have come to the post-intervention part, you have to make sure that it is completed in 1 to 2 weeks time. And it has to be done again with the adolescent as well as the caregiver, and you have to make sure that they are giving honest answers. Why do I say that honest answers only? Can anybody please answer me that? If you think about it, when we are doing an assessment, even of a child, what happens is that we are asking them कि जितना आपको समझ में आए उतना बताओ. हम ये क्यों बोलते हैं? Why do we say so? Why honest answers? Now, do often lie, but also if we are talking of this very situation that we are trying to put emphasis on, there is a very high chance that they have this expectation that we must improve. So that increases the chances of them lying, right? So that is why they want to be believed that they have improved. That is why they'll answer, probably better and through line. So that is why we make sure of these three things that has to happen when we are talking of the post intervention assessment. Now, when we are talking of post intervention assessment, again, this has been bifurcated into 4 different steps. The first step is again introduction and consent to participate in the assessment. Now, once the ease assessment and intervention has been done, what we are trying to see is that have they improved or not. So we are taking a measurement again to see and measure the improvement. So all the steps, even in the post intervention assessment, are being repeated. Only the demographic part and other history remains the same, but there are several assessments that have been sort of formulated by the ease manual, and they want you to ask those and then make a measurement and informed decision. Then comes your questions for the adolescents. So question for the adolescents, basically, again, what happens here is, now that you have given the intervention, still you would want to safeguard the space for the child as well. So it is necessary for you to ask that do you want an adult supervision over there or not. And again, the adult who is the caregiver, they may or may not want an adult with them, but the assessment for the child and the caregiver both has to be done separately, not in front of each other. So that is something that you need to take care of. And then we are straight away coming to the questions for the caregiver. Now, because the child has improved, when we are talking of improvement in terms of their internalizing issues, so now what you need to do with the caregiver is that you need to measure their emotional distress, how much better they have sort of come around it and now they are able to deal with it and overcome it. And other than that, you have to report their findings or however they perceive it when we are talking of their emotional distress in terms of internalizing the problem from the child's end. And then straight away you are ending the session with them as well. And I think that would be about it for the assessment part. And now lastly, I would like to invite Dr. Nishtha ma'am for her session. Thank you.
A very warm good afternoon to all of you. So, just to introduce myself, thank you, Prableen, for giving me over. So now, as first of all, I'm Dr. Nishtha Kumar. I'm assistant professor serving at IBAS. So now I would like to, talk about ease as we've listened to the introduction, the assessment, as my fellow colleagues have already talked about, a lot of models to be followed. So what do we do? What is like, the intervention specific thing that needs to come in? So this, as we know, as we've heard, that this is WSO and UNESCO specific, manual, which is already there as a curriculum, right? But this is specifically for adolescents. So there is an age range that is 10 to 15 years, right? So why are we focusing on social emotional learning or cell or seed or, this one, ease? Why is this so, adamant in today's world? And what is the need of, UNESCO and WHO, such higher authorities to get onto this and get it? Just anybody, if at all you feel. Right, 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 right. So I think what I personally believe is, as we are all clinicians and we've been dealing with a lot of crisis and a lot of, kind of different populations every day with different, same population with different issues, I would say. So I think it's now these things are coming, the self awareness, social awareness, because nowadays there is a high time need of including these things in an individual so that it's better to nurture a healthy kid rather than to repair a broken adult. So I feel, and now let's come down to ease. So yesterday also we had a workshop on social emotional learning. So just sharing an anecdote with you before I start with the intervention. There was a case I had seen in my clinical this thing. It was a 12 years old girl who was raped by a labor, just in front of the house. There was this mason and this building was getting reconstructed. And this girl did not tell this to anybody, neither the parents. And they got to know this when she turned 7 months pregnant. because of the maybe bodily changes or something, which she was not able to understand that what is happening with me. And this was such a major chaotic, event in child's life, and obviously with the caregivers also. So I think just to, obviously as a CSA, as a child sexual abuse, in a lot of cases, as we see, like as my fellow colleagues talked about suicidality and etc. But just to, repairing these things later on, I think this is the need of the hour. That's why this is there. It's early, identification and skill development in the child, that is social emotional learning, and then turning on to the adolescents. So this is particularly for adolescents and not the child population. So when we talk about theory of mind, be it a first order, be it a second order, why are we focusing it? Because that is what is eventually needed. Once you are aware of yourself, your emotions, your own body, then only can you be socially aware of the others, and how to, mitigate that, how to know that what is the, other person is feeling, and how to actually then resolve. And as clinicians, I think that is a big onus and responsibility on us also. Now, getting back to the topic, when I talk about ease, so there are 7 adolescent sessions and 3 caregivers. So that is 7 plus 3. That is what the intervention is designed as such in the curricula. So that is delivered weekly, and each session lasts for 90 minutes each. So when I talk about the session, they have, like, as we have already talked about the competencies and the skills, the 6 areas that my fellow colleague talked about. So no, just a second, yeah. So this is focusing basically on, emotional literacy and coping and problem solving. That is all ahead of the line. But what is emotional literacy? How am I assessing first my feelings? How am I literate about my own feelings? How do I first know them, name them? Then only can I do something about it. So that is emotional literacy, focusing basically the major initial sessions would be teaching that. Knowing my emotions for rather all of us, I think, is very important. Then the second, and then when you talk about the adolescent objectives in the session 1, that is identifying and naming basic and mixed emotions. Whereas when I talk about the caregiver objectives, since we are having caregiver sessions also, so understanding emotional changes that is needed in the early adolescence. So I think the Indian parenting somewhere goes wrong over there. And that is the turmoil time that we are not able to basically come in. And then that is, I think, role of we as clinicians comes in, wherein in sessions we can mitigate that in the parents also. Coming down to second session, which is emotion, expressing feelings safely. Now I'm, literate about my sessions, about my emotions, but how do I express them safely is also the session goal, which will be in the second session. So if I talk about the objective of this thing, this would be learning healthy ways to express emotions, because somebody might, just hit somebody, somebody might get in a room secluded. So there is a way of how individual, tries to express their feelings. So, and what could be the caregiver objectives? That would be model and support safe emotional expressions at home. If the parents are only so critical, so how would you, expect a child to do it or project it safely? So that is what we have to take care of. So expression of feelings safely. Coming down to the third session, that would be managing strong emotions. Now, since I've labeled my feelings and I know these are my list of big feelings, first of all, I wanted to know that. Now I've got to know everything. Now, how do I manage the strong feelings? So, what I personally do with my child is I tell her, so this is a lid, this is the watch that you're wearing, and now your lid has opened, and your brain is now, your emotional brain is working and your rational brain has stopped working. So she understood that lid up is that I'm doing something stubborn, something, not up to the mark, something which is not acceptable maybe. So I need to understand what do I need? Am I sleepy? Am I not liking this environment where I am in? So basically then trying to understand that, okay, if I'm not feeling, if I'm feeling sleepy, I should switch from this room to the another, go back and have a sleep, and then I think the problem will resolve. So that is environmental cues which are provided. So I think that as parents and as clinicians, we can always, talk about it more. So since we're talking about adolescence is something which is little critical to, tough nut to crack. So we can, mitigate little more effectively and cautiously the therapeutic techniques. Coming down to then managing strong emotions, as I mentioned. So we can practice calming strategies such as for anxiety, anger, sadness. So wherever we can have a safe corner, breathing room, or safe space wherever the child wants to go and sit for that like sort of time. Learning co-regulation and calming techniques would be caregivers' objectives, because simultaneously you need to educate them also on the same. Then going down to the fourth session, which will be empathy and understanding others. So as we've already heard that is one of the essential, thing of the therapy, and we all actually do that. Empathy is like one of the basic qualities that is needed in any clinician, but that is now not up to us. We are teaching that as a session. So what are we doing? We are basically recognizing emotions in others and telling them to how to respond to that in a healthy and effective manner. Right, we're all humans, because we also tend to crib or do something on this, but then that is how we need to tell them that this is a healthy and this is unhealthy way of doing it. So how do we tell the parents in this? We will encourage empathy in the family communication. Just because there is no empathy in the family, how do we expect the child to go and empathize with the others? So can always pour when we are full. We cannot pour from an empty cup. So then next session would be building confidence in self-talk. So nowadays, if you see, parents have started, positive affirmations. What we're doing later in sessions, parents have started doing that with the small kids also. So when I, just to give a personal example, I went to Mermaids of Arabia, which is in UAE. My daughter, she was taken in a group of like 5 to 6 girls, and she was dressed as a mermaid and everything. And you know what, what was the activity there? They had this song, I am brave, I am strong. All the adjectives actually came in. And this was a song in a sing a song like manner. This was done with them as an activity, then a circle time. So this was, I was amazed to see psychology and clinical psychology coming down to this level at a play area. So that was very nice. So basically trying to say that this is, yes, what is needed. Hence I started with my my speech with the same. So building self-confidence and self-talk, obviously that will strengthen your own positive mindset also. And then using praise and validation wherever necessary. That would be objective for the caregivers. The last session would be coping and problem solving. Since they've learned everything and they know how to cope and how to actually go and solve the problem, and not to be a cribber, rather to be a problem solver, that will be, they'll be applying those skills which are been taught as a curricula as part to their emotional life and their real life problem solutions, be it school, be it home, wherever. And then this is where the objective for the caregivers would be guided teens in problem solving without over controlling. So I'm not telling don't do this, don't do this, don't this. So I'm also sort of giving space to that child. Okay, you figure out this is your problem. As we mentioned, that this is, you're not there to solve, you're there to support. That is what I think we will be also inculcating that in the parents as well. So I think with this, this is just 2 session themes. As I mentioned, understanding my feelings, emotional awareness, calming my body, changing my actions, that is behavioral activation that we do each day, managing my problems. And as I've already mentioned about big feelings, as we know, power of praise, self-care, promotes empathy, bonds, and communication. And implementation, this is delivered by 2 helpers. So one is the lead and one is a co-helper. We also give some home practices and group reviews for each week, since I mentioned it's a weekly session. And supervision ensures quality and adherence, because as a parent, what you're doing, that also needs to be supervised. That is the power of supervision, along with community-based follow-ups and for sustainability. So some of the outcomes and impacts I would want to illustrate would be that this is a WHO trial which has demonstrated reduction in adolescents' distress, improved caregiver-child relationships and coping skills, and enhanced community mental health capacity. And that will be my references, since we know this is already talked about. And with that, I would like to end my speech. Thank you so much.
I congratulate all the 4 speakers. You're bringing up the most needed and topic for need of the hour. Now the session is open for discussion. If you have any questions or contribution, please feel free to. Anybody else?
We can practice if we want to elicit the information from the child or the adolescent.
Basically, what will be the core pillar to this? I would say is rapport. Because in many cases, if I talk about my clinical practice and experience, I had seen a lot of CSA cases in Mumbai also. So while I was practicing, so and usually these CSA cases which come to government setups is of very lower strata. I mean, if you talk about government setups, not that private setups don't have it, but that's majorly more over there. So, having said that, I think first few sessions is only rapport. Only rapport, I would say, would be the cornerstone. Why? Because once the child is comfortable with you, then only can you actually go on doing anything. First few sessions, rather, not even like one or two, few sessions, I would say. Even if it's silence, it holds a lot of value. Because once the child is connected with you emotionally, then only can you go for any basic assessment also, such as house tree person, or basic draw person, anything, any basic thing. So just to share one example, as you mentioned, so there was a CSA case. The mother was a maid, and this child was in Dharavi, the biggest slum of India. So she was being molested by her own chacha, uncle. So what happened when few sessions when she came, this is during my MPhil days when I was like, practice, we were the trainees. We did not know what to do, same as your, same boat. So what my supervisor told is that you first start, you have your rapport done, made. Then after few sessions, after, the child knew me and I knew her and basic, thing was there, that was not a objective of assessment. I just gave her a plain paper and a colors. So I told her, you do what you want to do, or you can maybe draw a person, ऐसे कुछ भी, a human body, and you will be shocked to see the results. When this lady drew, this child drew a human figure. This was a big giant male with I mean a big giant male, and on the other side it was a timid small lady, like a female, with a whole private parts area with black crayon sketched over. So I think that was enough for me to understand the interpretation and further go for the intervention. So I think that is what will help you sail through this. Thank you.
For your question, my experience, at least you need to have minimum 3 sessions. If you can able to catch hold the adolescents for 3 sessions, then you can able to make wonders in their life. So mostly what will happen now, they'll come for first session, second session they'll go out. So main important thing, you need to spend more time for building rapport. Don't discuss about any emotional distress or anything. If they talks, then you can engage those kind of conversation. Otherwise, you try to spend some time. Then any activity based assessments, especially the projective test, will be help us to find out the issues with them. Any other?
So just a follow-up question for this. Like with children, we can do tests like CSRPI, DAPT, house tree person test. But specifically adolescents, like those who are 12 plus, 13, 14, how do we proceed with them? Because a lot of time they are guarded and they're not giving us the information. So in those cases, how should we approach?
Projective test. Again, we have. Then TAT, sorry, dry person for them once.
Okay, so I would like to tell you something out of my experience. First of all, just because it becomes easier with the child doesn't mean that it is some kind of I mean, it's a rocket science with the adolescents. It's not. It's very similar with the adolescents as well these days. Yes, definitely, I agree with you on the fact that with adolescents, giving them the space to let their guard down, maybe in 3 dates, which we can do with a child is not something easy. But again, like ma'am has told us, that silence also is of an equal essence as much as speaking and vocalizing whatever is going on. So I think to the adolescents, especially the Gen Z and all of that, you have to give them the space to open up. There is a very high chance, at least statistics with my personal experience, the adolescents, most of them had left probably after the third or the fourth session, but they definitely came back in next 1 to 2 months. They did, because they realized with the time that whatever we are there to offer, nobody else is there, and it definitely takes a toll on them. Because now with adolescents, what is happening is they are becoming more aware, they have better insight than the child is not as much as insightful as an adolescent, and the adolescent is still creating that insight and awareness in themselves, right? So they do have that hit, and then they definitely come back. In most of the cases it does happen. So if the resource and other factors are not a problem, they do come back and seek help. That would be my answer to your question. You're welcome.
I congratulate all the presenters and the participants. This emotional skills are very, very useful, especially for preventing adolescent to having a major mental illness. And then these skills also help them to improve their academic skills and the social skills. So after listening the presentation, I also feel that this may be applied into the juvenile delinquent population. So that would be very useful to our community. Nowadays, if we can see that a number of delinquents are increasing, but the slide focusing only the internalizing behavior, maybe this can be applicable into the conduct disorder population also. Thank you.
Thank you, everyone. This brings us to the end of this enriching symposium. Now, we would like to begin the memento distribution ceremony. We would like to request Dr. Tarana ma'am to please come forward and present the token of appreciation to Dr. N. Suresh Kumar sir. Dr. Nishtha Kumar ma'am. Miss Muskan Marwa ma'am. Miss Riya Mahanti ma'am. Miss Prableen Kaur Chawla ma'am. Thank you, everyone.
Not each day. The supporters support the first half application will be available for the we will process it. Thank you.
स्पेस नहीं के बोल रहे आई फोटो के लिए नहीं बोल रही सर पहले फोटो सही नहीं मेरे को ना जाना है इसके व्हाट्सएप पे डीपी लगा दिया कुछ
Yes, ma'am, we have texted on the main CRM. Thank you. Good afternoon, everyone, and a very warm welcome to all present here. We are delighted to have you with us for the workshop titled Best Practices for Interviewing Children Insights from Forensic Psychology. This workshop focuses on a theme of immense social and clinical significance, understanding the nuances of interviewing children within forensic contexts and ensuring that such interactions are guided by empathy, ethics, and evidence based practice. It is my honor to introduce the chairperson for this workshop, Professor Dr. Kalpana Srivastav, ma'am, Director of Amity Institute of Behavioral Health and Allied Sciences. Dr. Srivastav, ma'am, is Scientist G from DRDO, Department of Psychiatry, AFMC Pune. She holds an MPhil in Medical and Social Psychology from the Central Institute of Psychiatry and a PhD from RINPAS. Her illustrious career spans 22 major research projects under organizations such as DRDO, DGHS, WHO, and AFMRC. She has played a significant role in developing the Manas app for positive mental health, a collaborative initiative under the Office of Principal Scientific Advisor, Government of India. Her contributions also include development of scales and test norms for the armed forces. Dr. Srivastav ma'am serves as a subject matter of expert to several government bodies, including Rehabilitation Council of India, Ministry of Social Justice and Empowerment, Ministry of Health, and Niti Aayog. With over 190 publications, 7 edited books, 12 book chapters, and more than 3,000 citations, she has made remarkable contribution to the field of behavioral sciences. Her achievements also include Chief of Army Commendation Lifetime Achievement Award, Shanti Niketan Mental Health Award, Colonel Kripal Singh Award, and numerous national and international honors. She is currently the president of Association of Industrial Psychiatry of India, vice president of Clinical Psychology Society of India, and former president of Indian Association of Clinical Psychologists. Her special interests lie in community mental health and positive mental health promotion. We are also deeply privileged to welcome our esteemed speaker, Dr. Victoria Talwar, a globally renowned expert in child and forensic psychology. Dr. Talwar is the Canada Research Chair and the Director of Gold Center for Early Childhood Development at McGill University. Her professional background spans child and adolescent psychology, psychology law, and forensic psychology. Her research focuses on children's adaptive and maladaptive development, particularly development of children's lie telling, the promotion of honesty, and design of effective interview practices to elicit accurate and truthful reports from children. Dr. Talwar's outstanding work has been recognized internationally. She is the recipient of King Charles III Coronation Medal and a Fellow of the Royal Society of Canada, the Association of Psychological Science, and the American Psychological Association. She is also a recipient of the Society for Research in Child's Development Early Career Award and David Thompson Award for Graduate Supervision and Teaching at McGill University, and several other honors for excellence in research and teaching. We are truly honored to have her to share her expertise and insights with us today. Now, first, I would like to invite Dr. Kalpana Srivastav ma'am here for the memento distribution ceremony, as well as I would also like to invite Dr. Victoria Talwar to receive the tokens of gratitude. Thank you so much, ma'am. Now, I would like to invite Dr. Talwar to carry on with the workshop.
Good afternoon. Thank you. That's what I wanted to hear. Well, this is going to be an interactive workshop, so you're going to be speaking as much as I am, but we'll start off with a little bit of information. Thank you. So first of all, you're thinking, okay, what does this mean? Insights from forensic psychology. So let me get you a little bit of background. I work in the area with children and adolescents, but in particular, I've done a lot of work in how do we interview children in a way to get their accurate and honest reports. And this is particularly important because when we're dealing with children sensitive issues like child abuse, sexual abuse, physical abuse, maltreatment, children have to be interviewed. And often it's psychologists that may be asked to do that. Sometimes it's police. Unfortunately, police are not always well trained in doing this. But psychologists have unique training that allow us to be able to do good interviews. But there's some principles that we have learned over the last few years about what are the best ways of doing that. And so we're going to share with you today some of those insights and why they're so important for you to understand the importance of why we do it in a certain way. Because when you know the reasons why, you're more likely to stick why to do that. And as part of this, we're going to do some activities. So as we go along at different points, we're going to break into small groups and 2s and 3s. I have some actual transcripts from actual cases that you will read together and analyze. And hopefully somebody's gone off to get another. I have also case examples that at the end we'll do role play where in pairs somebody can be the psychologist
doing the interview and someone can play the child. Hopefully we'll get those handouts for the end. So you can kind of put into practice and try and practice out some of what we're talking about today. So today we're going to cover briefly, I'm going to just go over children's capabilities so you have reasonable expectations of what children will or will not be able to communicate. And then we're going to talk about the bulk of it is these best practices that we have learned in the last sort of 2-3 decades. So what are child witnesses' capabilities? Well, there are a lot of myths that exist within the sort of general population, but also within the legal system. So lawyers, judges, and police officers. That is important to know because sometimes that influences how they handle children. One is there's a myth that children are not able to give coherent and detailed reports. Well, the fact is that children are able to communicate. Even by 3 years of age, children on average in their mother tongue have about 1,000 words. So you can imagine they can communicate, they just don't have as much vocabulary yet, right? So that makes it trickier in terms of trying to get their reports. But also, the terms that they're going to know are very concrete terms, right? They'll know a ball, they'll have the vocabulary for concrete, their toys, things like that, but they're going to have trouble with any abstract terms. That's important to keep in mind when communicating with them. By 4 to 5 years, most children have mastered their first language and that they have they're fairly able to communicate pretty well by 4 or 5. They still are growing in their vocabulary and they develop adult-like communication competence by about 10 to 12 years of age. Children do have communication difficulties. So young children have difficulties often with, for instance, like passive voice in English, which is the man was hit by the car. They may confuse that with the man hit the car. So you can see that sometimes children are communicating, but the confusion comes in that they're having difficulty in communicating. So we have to keep that in mind when we're trying to interview them and understand what they're trying to say to us and keep an open mind to figure that out. So for instance, little things can lead to misunderstandings, right? So preposition confusion is most common with young children. It's also common when we're learning second languages. Often you can tell somebody is using their second language because sometimes there's these little preposition confusions. So for instance, in this particular case, a 3-year-old boy excitedly reports to his mom after an access visit with his father. Dad put his pee-pee in my pee-pee. So the child was actually trying to communicate that the dad put his pee-pee on my pee-pee. So the dad was trying to teach the child how to urinate in the bowl, and after the child had urinated, after the father came in and urinated into the same bowl. So that has a lot of different meaning. You can imagine in the case of an investigation, right, of potential sexual abuse, it's really quite an innocent action that's happening here, but just because of those simple preposition differences that can lead to a misinterpretation. Children really, younger children, and in fact, most people, if you're trying to communicate with them, if you're using embedded clauses or double negatives or conjunctions, this can lead to misunderstandings. So this is a transcript from an actual case where a lawyer asked this of a 4-year-old. Oh, sorry, it was a police officer in this case. So he asked, when your mom took you to your uncle's house last Saturday, did you stay the night or did you drive back to San Diego and have dinner with your dad? And the child says, no. Okay. So now where are we? What do we understand from that? Well, first of all, we don't know what the child understood from the question because I had to take a moment and think about that question, right, as an adult. And 2, the police officer has gone nowhere. They've gotten no useful information from asking that question, right? They just get no, and they don't know what the child's answering. So it also behooves us to use simple language and clear language so that when we get a response for the child, we actually understand what they're responding to, right? And the thing that is important is notice the child didn't say, I don't understand, or I don't know. The children are socialized to respond. From a very young age, we teach children that when an adult speaks to them and asks them a question, they are supposed to respond back. They learn that from a young age. They're taught to do that. So we socialize children to respond to an adult, to a grown up, to an authority figure. And so they will often respond, even when they have no idea what is being asked of them. So they rarely ask for clarification or say they don't know. The other thing to think about in often in these cases, we're trying to get a sense, often time is something that we're trying to get a sense of. But we have to remember that children are mastering systems of measurement over their schooling years. So at the younger age, they still have, they might, they start, very young children may have trouble with counting. As they develop counting skills, but they still may not have really finite understanding of systems of measurement, especially time. So for young children, things that have happened in the past are yesterday, and things that are happening in the future are tomorrow, but they don't necessarily have a fine grain of sense of like this happened literally yesterday versus this happened a week ago, a month ago, a year ago. So this is an actual example from a case. This was a lawyer who asked this, and asked this as 6-year-old, do you remember when it was? Was it a day ago or a lot? And the child answers, a day ago. They picked the first answer, a day ago. It was 1 day ago this happened? Okay, what time of day was it? I think it was 6 o'clock. 6? So it was the afternoon, child says. Afternoon. Where was your dad? At work. Oh, he comes at 4. He comes at 4? He hadn't come home from work yet? I think he comes at 9 at night. Oh, he gets home late. Is it dark outside when your dad comes home? I don't know. He doesn't tell me. Oh, are you awake when he comes home? No, I'm asleep. So you can see their child is there's a lot of confusion there in terms of time. So children do have problems with getting time. And so that can, for getting precise time points, it can be difficult with younger children. So generally, when speaking to children, it's best to avoid jargon and abstract terms and use very simple, direct, short sentences. 5 to 7 words, not a lot, not very complicated sentences. If you're interviewing them and you're going to be talking about, anything that relates to time or numbers in any way, it would be good to sort of do ascertain baseline knowledge of numeracy and time before you interview them. Do an assessment of that. And to clarify and encourage them to say that they can say, I don't know to your question, or I don't know the answer, or if you are saying something, they can say, well, no, that's not right. You got it wrong. A second myth is that children do not have reliable memories. So often it is thought that children can't report. This is sometimes leads people not to investigate when there's claims of potential sexual abuse or physical abuse because of the idea that children are not reliable reporters. But I advocate that children actually can be reliable reporters. It's just how we interview them. So this is going to be a theme throughout. An interviewer needs to get out of the way of the child giving a good report. We have to adjust our expectations. A young child is not going to give you all the details in the world. So we should not expect it. But we should try and interview them in a way where we can get as many details as that child is able to provide. And they can provide some details because they do have some memory. So I'm going to just do a little demonstration of memory. So I'm going to say a series of words here. You can see if you can remember as many of them as possible. Don't write them down, just try and remember them in your mind. So here are the words: rest, tired, awake, dream, snore, bed, pillow, slumber, sound, comfort, wake, night. All right, so by a show of hands, tell me if you remember these words being in there. So chair. Anyone remember? Oh, okay, bed. Okay, a number of hands. Yep, a lot of hands. Sleep. Okay, also quite a few number of hands. Okay, so nobody remembered chair because chair doesn't really fit into the script. A lot of those words are about like bedtime kind of things, right? So no one forgot about that one. But and bed was in there, so people remembered that, but sleep was not. So a lot of people thought they remembered sleep. That's because sleep is very close to some of the other words that were in there, like slumber, for instance. So you see, we remember things based upon the scripts that we have. And so it can be easier for us to remember some words because they're part of the script, like bed. But it also is because of those scripts can make us misremember other things being present that weren't. Another example of this is a famous study by Ornstein where they had children between 4 and 6 have a medical examination. And it was performed by a pediatrician. And in that, sometimes they had typical components. So like typically if a child is having a checkup with the doctor, the doctor may put a tongue depressor and go, check the reflexes, these kind of things. So they had typical components, but there were also absent typical components. So for instance, taking the stethoscope and listening to the heart is a typical component, but it was absent. They also had atypical components included, like measuring the circumference of the head. Normally, that's not part of the normal checkup. And they interviewed children 1 day and 12 weeks later. And at 1 day, few children mentioned the absent components. So few children reported that the doctor went and listened to their heart through the stethoscope. But at 12 weeks, many of the children remembered those absent components happening, like listening to the heart, because it's part of the script of what normally happens when they go see the doctor. So over time, their memory changed so that it included part of these things that actually didn't happen. So our memory is not like a video recorder. Unfortunately, we can't go back and just replay it. Our memory is malleable and it can be affected by these scripts by prior knowledge and expectations about events. So there are 3 stages of memory. The first stage is the encoding stage. What we attend to gets put into our memory, but not everything gets into memory. So young children encode less due to limited processing speed and attention, and these skills increase with age. There are other factors that affect children's memory and adults' memory, all of us, and that is familiarity with an event. We are more likely to remember things that we have more familiarity with because we have scripts for them. And so our memories that helps us remember. Also, interest value. If you are interested in something, you're paying attention to it and you're more likely to remember the details. If you're not so interested in something, you pay less attention to it and you're less likely to encode that into your memory. If you understand the details of the event, you're more likely to make meaning out of it and encode it in memory. That's important for children. Children, if they understand what's happening, they may remember it, but if they don't understand what's happening, they may not encode certain details. So for instance, in the case of sexual abuse, young children don't have knowledge about the sexual act, for instance, and so some specific details may have no meaning to them and they may not encode those properly into their memory. And also stress level at the time. So stress can enhance memory in a flashbulb way. So we've heard of flashbulb memories where you remember something because it's so dramatic and sudden, and you remember central events about it. But stress can also negatively impact memory. If you're undergoing a lot of stress, you're often not attending to a lot of details at that time and you're encoding less. So there's the storage part of memory where we basically shelve our memory, put our memories on a shelf, and we divide that into short-term and long-term memory. But information is not frozen in memory. It can actually decay and change over time. So older children, adults have greater capacity to take stuff from short term and move it into long term. Younger children are less likely to move things from short term into long term. And that's why we have what we call infantile amnesia. So if you think back to your childhood, if you think back to 1 year of age, your memories of 1 year of age, 2 years of age, 3 years of age, 4 years of age, okay, now some of you are having memories, somewhere in that 3 to 4 range, you have maybe your earliest memory. That's because we have infantile amnesia. We don't tend to remember much in the first few years of our lives because we're encoding things into short-term memory, but not that much is getting encoded into long-term memory. And the last stage is the stage 3, which is accessing and recounting stored information. So retrieval is also not perfect. Not everything we have in our memory we can always recall. So everyone's had the experience where they're like, I know that, but I just can't remember it right now. And so children are also have greater difficulties with this because their processing speed can be more limited for retrieval. So generally, preschoolers recall less, but are highly accurate regarding the central details of what happened. So they may not be able to give you as many details, but they can give you a few more central details. And they are able to remember often those central specific details that they have remembered over longer delays, and this improves as they get older. So for instance, they found that 2.5-year-olds could remember some of the central details when they had to go to the emergency. When they were interviewed about going to emergency 6 months later, they remembered some of the key details, and they could remember it a year later and 2 years later. Not loads of details, but some key central details. That ability and the amount of details that were remembered improved as the children got older. So by 4 years of age, they remembered a lot more compared to 2.5. By school year age, we no longer think about it in terms of age, but rather more in terms of individual differences. So the third myth is that children are unreliable because they're vulnerable to suggestion. So what happened in North America in the 1980s was there were these cases that happened famously there where children, there was cases where a suspicion of abuse, and interviewers went in and zealously interviewed all the children in these daycares. I believe there were a couple of these cases. It was also before my time. And they became sensations because they interviewed all these children, and suddenly they had like a case where at the daycare, 20 kids were, there was abuse cases coming from 20 kids or more, and it was like abuse and ritual abuse and satanic abuse, and so it went to these court cases, and ultimately what came out of it was psychologists were looking at this and going, whoa, and then some of them realized, wait a moment, how are these kids questioned? And in looking at it, they realized the kids were questioned in a very suggestive way that led to a whole lot of false reports. And so this led to a whole lot of research in psychology about suggestibility. Now, I'm going to tell you a little bit more about that, but I just want to make the distinction between two types of false reports. There's suggestible reports. These are unintentional false reports. So those children, those famous daycare cases, those kids weren't intentionally making up false stories. The ideas were suggested to them the way the interviewer conducted them, and they incorporated those into their memory. So they were giving unintentional false reports. Lies are something different. That's when someone is intentionally giving a false report. So suggestibility is something we have to be really mindful of, because that's where the interviewer is getting in the way of the child giving an accurate, truthful report. So questions that suggest answers can unconsciously and permanently distort memory. So Stephen Ceci famously did this study. He was one of the researchers who watched these cases and said, wait, what's going on here? And he started looking at it and studying it. And so in this particular study, they went into classrooms and they had a magician come in, and the magician did all sorts of tricks, like a rabbit out of a hat and all the fun things. But they later had the interviewers go in and interview the children about the magic show and what they saw. And for some of the children, they were in a condition where they were interviewed with suggestive questions that suggested that the rabbit got loose in the classroom. And then they interviewed the children later after that was suggested. And what they found was in the orange, you have non-suggestive interview. And you can see, if you just look at the orange bars right now, you can see that even 4-year-olds are pretty accurate, over 80% accuracy. So even 4-year-olds can be really accurate with non-suggestive interviews. But when they looked at the suggestive interviews, those children were very vulnerable to suggestion. You see how on the yellow it goes way down, it's below 40% for the 4-year-olds. And it goes up as children get older. So young children are particularly, preschoolers are particularly suggestible, more so than older school-age children. But it's important to note this, that school-age children and adults are also suggestible. And if you want to know about the adult suggestibility literature, I suggest you Google Elizabeth Loftus, Loftus. She's famous because she did research. Her research was the first research to show that in therapy sessions, adults, the therapists would say things that would suggest abuse or do hypnosis where suggestion was given to the adult clients about abuse, and they would come up with false reports about abuse. And she looked at this, and at first people were like, no, this is not possible. So she got a lot of flack, but they did this research is now well established with her, many others, that we, even adults, can be suggestible. If you interview adults in a very suggestible way or prime them in certain ways, you can cause adults to have false memories too. So what makes children vulnerable? Well, one is that, as I said before, they have been socialized to comply with authority. And they have a belief in others' knowledge. They believe, well, you're the adult, you're the authority figure, you must know better than me. Because adults usually know better, right? So you've suggested something, I didn't really think that, but if you say it, it must be true, and they incorporate that into their memory. Interviewers having prior beliefs can affect the outcome of the interview if suggestive questions are used, because having a bias, you can lead you to want to get that answer that you believe. So this is actually very seductive and hard, because if you're seeing a child where you think you have real good reason to feel or think that this child is being abused, of course you want to get that report because you want the abuse to stop and you want to be able to have charges laid on the perpetrator or get the child away from the perpetrator, right? So, but what you have to do is almost lean back in an interview. It can be really hard. It's really hard on the interviewer. Psychologically, it's hard because you know you so want the best interests of that child, but the best interest of this child is to not come in with a bias, but to try and keep an open mind, because you're going to see how interviewer bias can really taint an interview. And I'm going to give you an example in a moment. Also, interview frequency. Repeated suggestive interviews can result in false memory. So if it gets repeated over and again, you're reinforcing that memory, and that becomes a strong memory. So here's an example. So in the interviewer says, Jay says you won't see P or Daddy if what? Child says, if they hurt themselves. But that's not what the interviewer interviewer wanted as the answer. They have a particular idea of what happened. So the interviewer says, doesn't rest. They go, you mean if you tell the truth? So they've just suggested to the child what the answer is. Child, that's not what the child originally said. The child goes, repeats it. You mean if you tell the truth, you wouldn't see them? Child now acquiesces. Later in that same interview, the interviewer says, what happens if you tell the truth? I won't see P and Daddy. Child's learned the answer and comes up with it there. So you see, that never originated from the child. That was suggested by the interviewer. So is that a correct statement or not? We don't know, because we didn't let the child say it. It came from the interviewer, and the child could be just basically has learned that that's the right answer. When I ask you this question, the interviewer is basically communicated, this is the answer that you need to give me. So you can't now, if this was a case, you couldn't charge on the base of this, right? Or if you did, it's on very faulty testimony, and they might get somebody like me to come into court to say basically, This is no good. And so repeated questions can result in false memory. So here's another example. Interviewer said, did M tell him to stop? Child says, we were playing. That's not what the interviewer wanted, but M told him to stop. Yeah. Child gets, okay, the first answer was not correct. Yeah. Who told him to stop? M. Child's got on board. They got on the page. Okay, I'm supposed to say M here. A little while later, the child randomly, not randomly, but later in the interview brings up that. Then M told him to stop. So the child's now incorporated that into the narrative. Did that happen? Well, actually, we just don't know because the child never said it. It was based on a suggestion of the interviewer. So the interviewer has completely gotten in the way of this child's report. So we don't know what actually happened anymore. So studies have shown that reports that emerge in the first interview with a neutral interviewer are often the most accurate. So ideally, the earlier on that they're interviewed by somebody who knows what they're doing, the better it is, because those ones are less likely to have, any taint to them. Because even this child, if an interviewer comes that is not biased after this, the child has been practicing it with this interviewer so many times that it now may be in their memory. And the other thing is to know that repeated suggestive interviews can result in very credible sounding testimony. It sounds very credible once they practice it because it's a rehearsed now report, and they can be really hard to determine. Okay, so that gets us to interview questions, good and bad types of questions. So we're going to go over these, but basically there's a continuum of good questions, which are these open-ended and cued recall WH questions, going down to bad questions. So specific WH questions, what color were the man's shoes? That's bad if the child has never mentioned, for instance, the man's shoes. Now you're adding something to the child's report. If the child's mentioned the shoes, then you could ask that up. That's an open-ended question. Yes, no questions. Did he touch you? Was he angry? Demand a yes or a no. Forced choice questions. Did you eat dinner or watch TV? Or tag negative term questions. Mike played with the toy, didn't he? Didn't you see the toy? Those are very problematic. So tag questions like he touched you, didn't he? These communicate the interviewer's bias to the child. It communicates what they expect then. That he touched me, yeah. Suppositional questions, what happened after he shut the door? So that's a suppositional question. If the child's never mentioned shutting the door or going, then you're supposing something and you're adding a detail. So it presupposes information. These look like open-ended questions. It could be an open-ended question if the child said, and then he shut the door. You could, a follow-up that is not a suppositional question is after the child says, and then he shut the door, what happened after he shut the door? That's okay. But if the child hasn't mentioned it, then it's suppositional. Forced choice questions, we ask these to children all the time, but these are really, you need to be careful of them. You're looking for questions where you basically are using the word or. Were you at school or were you at home? The problem with these is they're close-ended and they lead to more errors. For instance, children, I told you, are socialized to answer, so they feel like they have to answer that. And even if they don't know the answer, they'll answer something. So younger children, for instance, often will give you the last item they hear, or they'll just jump to conclusions like that time question where the person didn't get a chance to say the or, they pick the answer right away. So they'll just guess. And sometimes neither choice is correct. Like they weren't at school and they weren't at home, but they feel that they have to say to one of them, and rather than tell you it was another option. The other thing about them, yes, no questions are also bad because the child, sometimes you'll just get a head nod or a yes or a no, but they don't often give you a lot of information to begin with, so they force you to ask more questions. Like remember that police officer that asked that convoluted question and he just got a no. He didn't know anything more at them. So you need to be careful of questions that start with did, was, can you tell me, do you know, anything that can be answered with a yes or no, because children, as I said, are socialized. Very young children are often have yes biases. They'll just say yes to everything. A little older, they can sometimes have no biases. We'll just say no to everything. And they'll guess, and they don't tend to elaborate on yes or no questions. So like that child who said no, they didn't say no, I didn't have dinner with my dad. They just said no. And so often they don't lead you with much more information. You have to ask a whole bunch of other questions. It's better to ask an open-ended question and get them to generate something and then move from there than just a yes/no question, which often leads you not very far. So the best are open-ended questions, which are less leading. So tell me more questions like, you said X, you said he shut the door. Tell me more about that. Or you said he went upstairs. Tell me more about when he went upstairs. Or what happened next? You said he went upstairs. What happened next? WH questions are like the who, the what, the where, and the how when they're relating to what has happened. So, you said he left. Oh, when did he leave? That was okay because you're following up from what they've said. Research has shown that these really do have an impact. So for instance, we have 4 and 5-year-olds are the light blue and 8 to 9-year-olds are the darker blue. And you see when they have yes or no or forced choice questions, FC is forced choice, they give very few details at both ages. But when you have tell me more follow-up kind of questions, you get a lot more details. A lot more details, especially with the 8 or 9-year-olds. You still get more details with the 4 to 5, but no, not as much as the 8 to 9. And that's an expectation you have to have. With the younger children, you're just not going to get as many details as you get older. And that's just part of, at that point, their vocabulary isn't as much, their processing speed, etc. So now we're going to break up into 2, 3s, and these are actual transcripts. And yes, thank you. So you go to in small groups, read through these transcripts and try and identify the types of questions the interviewers are asking. And try and see how many details, like know how much details is each interviewer getting. Just make a rough count. You're going to have there's a bad interview in there, and there's also better interviews as well. So you can see what a bad interview is like and what a better interview is like. So read those. We'll take time. You can do that in pairs or 2s or 3s together to identify, and then we'll come back. So these are actual cases. So these are transcripts from actual cases that you're seeing. Okay, I don't want to rush you, but because of time, I'm going to. Sorry. So I'm just going to go over, you can take these with you and finish reading them because you may not have gotten to the last one, but I'm just going to go over a little bit of it so you can see. So this is from the first interview with the 4-year-old, and this was done by the police, this interview. And so you can see the police officer said, "Can you tell me what happens?" So that's a "can you tell me" question. So that's a yes, no question. And they get a no response. Nods. Okay, well, that's not useful. So they have to come in with another question. Did somebody get hurt? Uh-oh, another yes, no question. And they get a nod, so they still haven't gone that very far. Oh, here we get better. We get, who got hurt? Who got hurt? Me get a detail now. My mom. Your mom got hurt? How did she get hurt? So that's better. And we get a detail. Cause she fight with grandma. So now we finally got some detail. So you can see there, later, that same child was interviewed by a forensic interviewer. So that was yes, question. Yes, because if that hasn't come up, yes, yeah. And so that shows you not a good interview, right? You're not getting much from it. So a week later, a forensic interviewer, so this was a psychologist who's trained to interview children, came in and asked, so they did some, rapport interaction with the child, and they said, "Now that I know you a little better, Jay, tell me why you came to talk to me." Because the child's already spoken to somebody already. That's it. "Tell me why you came to talk to me." Child doesn't respond right away. So the questioner, you have to be very patient. "Tell me why you came to talk to me." There's a long pause, really long pause. If you see the video, you have to be really patient. They're often reluctant to talk about these things. They're not going to be jumping to respond to you. And that's where we run into trouble, because we want them to start talking to us. So we jump into the "did this happen, did that happen" question. So like this interview, you have to be really patient. So the questioner tries, "Well, I heard something. I heard something about your mom." Because the child's already talked about the mom. So tell me what happened. The child's still not responsive. So the questioner just repeats that. "Tell me what happened." Now finally the child says something. "I heard mom fighting grandma." Now the interviewer does not get in the child's way. They just use a facilitator. "Oh? Yes, mom was killing her by the bike. Yes, my grandmother's bike. That's what mom was doing." So here we got way more detail. And the interviewer's just starting. So you see how that's a good example of how we don't want to get in the way of the child, but we have to be really patient. So using open-ended questions is not some panacea where you're suddenly going to get the whole response. But if you do get it, you're going to get more detail. If you got to the last interview, that's an example. I wanted to give you a good example of where the child really opens up pretty fast. So sometimes it can be like that. So that's an actual case where the child opens up really fast. But notice though that I put in the pauses. They didn't get there right away. So when I say fast, I mean not after many questions, but the actual time it took to get there was long, and the interviewer was really patient and stuck with long, awkward silences, and then kind of just repeated the open-ended questions. But the interviewer didn't get in the way, didn't ask yes or no questions, didn't try and jump in there, and just patiently waited until the child finally gave the report. And then they didn't get in the way, they just let the child keep speaking. And the child then gave a very long, it's like a paragraph, right, response. That gives you so much detail right there. In the child's voice. You can now go back, keep notes, and ask them specific things. "Oh, you said he broke the window. Tell me more about that." That's come straight from the child's what they said. But you're not having to suggest things. So if it's not always going to be perfectly like this, but if you're patient, you can often get a lot more in the hands, and then it's much more reliable as a result. You know that it didn't come from you, it came from the child. Was there there was a hand up? Yes. Yeah, so you noticed that. It's a very good point. Thank you. So yes, the 11-year-old, this is an 11-year-old. So you're not likely to see that kind of response with a 4-year-old, frankly. But with 11-year-old, these can be very effective and you can get very detailed response. 11-year-olds can give you a lot of information. But the key to remember is they're not always rushing to tell you. They're going to be reluctant. So you're going to have to be patient, establish rapport with them, and just wait. Okay, so I talked about false statements, and we're going to talk a little bit about lies. So these are intentional false reports. So lies are different. There are different types of false reports. So lies are a verbal statement with the deliberate intention to create a false belief. I know what actually happened, but I'm still telling you something else, intentionally to make you believe something else. Young children can confuse this. Yes, question here. So then that would be in the interview, they came, they kind of just asked the child so you said, what was it? And it was a knife. So the second interview is the accurate interview. What the detail was what happened, so. Yeah, it happened by a bike with a knife. So you would just clarify that and then later, you said this, tell me more about that and get what the child would say to clarify it.
So we do a third interview for that.
No, you might just do it later on in the interview, or if you had to, but you would, just if there's something you need to clarify, you can use the child's new words, like, you said this, tell me more about that, and then you get them to, and they'll say back, repeat why, and you get clarification.
Right,
thank you. And if you have to use close-ended questions, sometimes you may need to, like, so you said he stabbed, you need to know, you would use that after you've got as many details as possible in the open-ended, and then you can go for the close-ended, because you're less likely to be suggestive at the end, right, if you're doing that. So,
right. Thank you.
So sorry, mistakes, other hand? Yeah.
Creating a rapport. But if something like this, a traumatic experience happens with a person, how do you exactly talk about a birthday party or
So that's rapport. That's rapport building.
No, but how do you expect them to converse when they've seen, like, generally when you're like in such a situation where someone is
Oh, let me tell you, children don't want to talk about the traumatic event. They do want to tell you about the birthday. So when they don't know you. You are a stranger that they're meeting now. They don't want to be talking about sexual abuse or their grandmother being murdered or anything. They just don't want to be in this situation. So when you come in and you talk about neutral events with them in a relaxed way, they start to decompress. Okay, we can talk about this. You get them feeling comfortable talking to you about the non-substantive issue. You don't dive into it. If you dive in cold, you probably won't get much from them. You need to establish rapport with them. It doesn't have to be a birthday. It can be, like maybe the kid's into football and you talk about football with them, or their video games. But you just get them talking to you and get used to talking to you and giving you details and opening up about something that is nothing to do with the substantive issue, because you need to develop some rapport with them. So
it's not like a state of shock response. So, like, for example, the situation or the day starts out with a birthday, and then the incident happens.
Oh, no, this is not about the incident. This is a non-incident related. So tell me about your last birthday. What'd you do?
Oh.
Right? Yeah, it's not about it. In fact, you don't want it to be about the event to establish rapport. You want it to be about some neutral thing that the child has positive feelings about and they can just chat to you about. So
Thank you.
So just so that children can mistake lies, mistakes with lies. So that's when you unintentionally say something. So if you ask me, if where's the bank, and I tell you it's 2 blocks down to the right, but I got it wrong and it's actually only a block down to the right. I didn't lie to you. I just made a mistake about the location, right? Children can confuse that. Also, sarcasm is another false statement. If I'm in the middle of winter in Canada and I say to you, isn't it lovely, balmy weather we're having? You would know that that's a false statement that I don't believe, and I also don't intend you to believe. So it's not a lie. I'm saying something sarcastic. So young children have trouble. They understand false statements, but they tend to understand all false statements as lies. So they overdo that. So young children have a basic understanding of the concept that it's a false statement, and they rate things as bad. Lies are bad, but they will confuse things like mistakes as part of that. By 6 to 9, children know the critical element is the intentional bit, that you're intending to create a false belief. And they start to distinguish between different types of lies. What is the intention behind? Was it antisocial, personal gain, or were you trying to do something more pro-social, for instance? And the same with promising to tell the truth. Young children, 3 to 4, have difficulty really explaining that to you. They'll make a commitment, but they have a harder time understanding it. 5 to 6-year-olds can give you an example, like if I promise to brush my teeth before bedtime, it means I have to brush my teeth. And 7 to 8-year-olds can kind of give you more definition and give you examples. And if you saw my lecture yesterday, you'll know that I showed this graph then, but basically young children can lie, but they're not very good lie tellers. It's as children get older that they're better at maintaining their lies. So in terms of our concerns, when children were getting reports, we don't have to be overly concerned that they are sitting there trying to lie to us. Usually they're not, and when they are, they're not going to be very good. Often their lies can be transparent in their verbal reports. I'm running out of, I'm going low on time, so I'm going to go through this. I'm not going to show you all 6 clips because of the time, but I'll show you a couple of clips of children, and you have to see which one is the liar of the 2 kids, okay? So children were interviewed about an interaction. So the researchers, there's a study where we went to the homes and we did a bunch of things with children, including playing games. And then in this part of the study, for some of them, the researcher that went to the home played the picture game with the children. And for other children, they didn't play the picture game with the researcher, but they were coached by their parents to say that they played a picture game. So we do this because we cannot ethically create situations like abuse and that to then replicate. So this is an analogous type of situation. It was where children can be coached sometimes, often by an adult or somebody else close in their lives, to give a false report, to say something happened that didn't, a false allegation. So we were looking at that. And so I'm going to show you 2 kids, and you'll see if you can determine which one's telling the truth and pled the picture game and which one's lying.
There's a big board and there's 4 cards glued onto the board. A cat, a dog, a train, and a bird. She has one of those cards in her hands, and it's flipped over. So I have to try to find out what card is in her hand. I go, does it bark? If I thought it was a dog, and she'd go, no. And if it was a bird, I'd go, does it chirp? She'd go, yes. And she'd flip over the card, and I'd get 3 stickers somewhere.
Okay, and then we'll do this one.
We played the picture game like this. She laid out 4 cards that were about that big and that wide, and they had pictures on it. Yeah. And she had pictures that wide, about that this tall, that wide, and she would have it in her hand, and she would say, "All right, we're ready." She would and I had to ask her questions. Yeah. like yes or no questions. And I eliminated the ones that I didn't think the picture was on. Then when I thought I knew what one it was, I would say the name of whatever it was. Right.
Okay, so who thinks A is played the picture game, is truthful? Okay, few, and how many B? Few. Okay, not bad. So A was the one who was lying in that case. So I'll do two more, and then we'll move on. Actually, I'm going to skip to this one. So these ones where you were asked close-ended questions.
Okay, did you really play the picture game? Yes. Did you make up this story? No. Did you and your mother make up this story? No? Okay. Did you really play the together game, Brandon? Did you make up this story? Did you and your mother make up this story? Okay.
All right. So who thought A is telling the truth? One. Okay. Two. Who thought B is telling the truth? All right, it's the opposite now. So A is telling the truth and B is lying here. So we got about 50-50 chance in terms of it, but you shouldn't feel bad because when we show this to lots of different people, you can see that people are at chance level. And basically, we're not good at detecting lies is the main thing when we look at them. So yes.
The girl is more descriptive regarding the situation. The second video, the picture game wala, the video, she said that it's just this big and this wide. She didn't talk about it. But the other girl, the first video, she was talking about the photos within the video. So when there's no description, you would expect that the person is not lying, right?
Yeah, but she was. The other one, if you look at the transcript, the other one is actually more descriptive. So the second one, the truthful one actually gives us more detail. If you look at you write out the transcript. So detail can be it, but you can see how coaching can lead to very credible reports, right?
Verbal cues as well. Like the child in the second slide that you showed, he was smiling when you said, when she said, "Did you make up the video with you, well, the game with you and your mom?" So that non-verbal cue, we generally associate people are lying when they start smiling.
So the answer to that, and everyone listen very, very carefully, there is no Pinocchio's nose. You are never going to know if someone's lying based on one nonverbal behavior, ever. And if you go to a workshop where somebody is telling you the opposite, then they are not trained as a psychologist and they don't know the literature. I am telling you that there are papers upon papers upon papers that have investigated this, and there is really no one nonverbal cue that tells you. But the media loves to print lists of this is the way you can tell your boyfriend's lying to you, or the top 1 things that the FBI uses. Like they love it, and you'll find it all over the place. And also, people will make their money giving workshops to it. I was doing a workshop for lawyers, and then the woman was saying, "Okay, and next week we have this guy," and she was telling me this guy's coming in to teach them all the nonverbal behaviors. I was like, "Oh my God, it's not based on science." So the fact is, you may know your one child, you might know that child does an idiosyncratic thing that child does, but that's individual to a child. There's no one thing we can say, like, when the person looks up and to the right, they're lying. Nope, it's not the case. And in fact, a lot of markers of lying are actually markers of just nervousness and anxiety. So, like, I remember once being in the line for the customs, security line, and the guy was training someone. I overheard him said, okay, you know, not making eye contact, looking kind of fidgety, sweating, things like that. And I thought, I couldn't believe he was saying that. I didn't say a word because I wanted to make my plane. I didn't want them to detain me. But you know, if you're nervous about flying, you could be looking kind of shifty in security because you're like so nervous about getting on the plane and you just have fear of flying, right? But the same things that can look like a so-called liar can be just person being very nervous about something, right? They're just nerves. Okay, so what can we do? So so in terms of lies, we're not going to be able to reliably necessarily always detect them, but what can we do to inoculate ourselves? Well, first of all, the thing is that the majority of children are often not lying. So, you know, it's only in small cases that you're going to see that. Most of the time, they will disclose, but if there's something that happened, but maybe they'll be reluctant. Or maybe they won't disclose because they totally don't want to talk about it. And also that is a problem, right? Children don't disclose abuse sometimes until much later. One thing we can do is instructions. These can help us in sort of inoculate the child from sort of us doing anything that can kind of sway them. And I'm going to go through the instructions really quickly, but the key thing is to give them one at the time, to make sure they're easy to understand, and to give appropriate feedback. So I'm going to walk you through it a little bit. But generally, the research finds that these do help to increase accuracy. They do decrease the inclination to guess, and they increase children's willingness to ask for clarification. And as a result, they are also more resistant to suggestion. They work a little less well with younger children. Younger children are always more vulnerable. And if there's really been suggestive interviewing already happening, that can overwhelm them if you're coming in after multiple other interviews have happened. So for the don't know instruction, you would, walk them through it a bit like this. If I ask you a question and you don't know the answer, then just say, I don't know. So if I ask you, what is my cat's name? What do you say? And the kid's like, well, I don't know your cat. And you say, or they might just look at you like fearful, and you can say, well, okay, you can say, I don't know, because you don't know my cat. What if I ask you, do you have a cat? And the child says, I don't have a cat, or I have a cat. And you can say, that's good, because you know you have a cat, right? Don't understand. If I ask you a question and you don't know what I mean or what I'm saying, you can say, I don't know what you mean, and I'll ask it in a different way. So if I ask you, what is your gender? What do you say? So if a young child often doesn't know what that kind of word is and say, okay, because gender is a hard word. So if I ask in a different way, are you a boy or a girl? So you're demonstrating it to them. That's wrong instructions. Sometimes I make mistakes or say the wrong thing. When I do, you can tell me that I'm wrong. So if I say, you are 40 years old, what do you say? And the kid is like, ah. You say, okay, so how old are you? And so you're demonstrating to the child that they can say, that's not right, I'm not 40 years old. And it's funny for the young child, but it also gets them the practice and sees that they can do it and nothing bad happened. The interviewer instruction, this is important for suggestibility. I don't know what happened to you. I won't be able to tell you the answers to my questions. That's important to say because they often think that you know better than them. And so you're letting them know, I actually don't know what happened. And that's important. So this is just quickly to show that these really do improve children's accuracy when you give these instructions. And then finally, promise to tell the truth. It's very important that you tell the truth. Do you promise that you'll tell me the truth? Are you going to tell me any lies? That doesn't wipe out, if they have been coached to lie, it may not wipe them out, but it can certainly, our research shows that it can certainly improve. So when they have promised, they're much less likely to maintain and get the lie. So in the interview, the first stage is you need to establish rapport. That's really important. Before you get into the substantive, you need to make them try and feel relaxed. And you also need to clarify what the interview is about and the role of the child. So that's where instructions become important. The other thing is to keep fatigue effect in mind. So you want to establish rapport and go over these instructions, but it's a fine line. You don't want to take so long that the child's now really tired. Like a 4-year-old only has so long attention span. So you really have to be careful about juggling that you don't get them so that they're so tired by the time you've gone through those first phases that they're now not too tired to even talk about the substantive phase. So this is something that has to be kept in mind. You need to avoid emotional displays. So you need to keep very neutral effect, positive effect when they're telling you about something fun or whatever, but you need to be careful not to show reactive displays, even though they may tell you things that are horrible. And confidentiality is something. So depending, there are cases in a clinical practice, you can give them confidentiality, which may make them feel better that because they may be things that they don't want their parents to know, that they want to disclose to you. So earlier I was at a talk that was about non-suicidal self-injury. That's something where kids often do not want their parents to know about that. And so they may eventually open up to you and talk to you about it, knowing that, they're in a safe space and it's confined to you and them. The thing to know that, however, if you're talking about potentially abuse or maltreatment, then you're not going to be able to keep confidentiality in those cases. So you have to keep that in mind when you're doing those types of cases. That sometimes that's already, they know that, but sometimes you may have to, if it came up within, say, a clinical setting, you may have to talk to them about having to break confidentiality. Getting into the conversation is the hardest bit. So you saw that in the good interview, an example of how that interview got into it. The tell me why you came here today, because often in forensic contexts, they've already made the first disclosure, sometimes to like a teacher or a parent or somebody, and then they've been brought to you. So if you already know, you can, and they've already disclosed, you can start off that way. Or I heard that X said something important, tell me about that. Or you said X, tell me what happened. Or is your teacher worried about something that may have happened to you? Tell me what they're worried about. Or I heard that someone might have bothered you. Tell me everything about that. Or I heard that someone may have done something to you that wasn't right. Tell me everything about that. So again, you're using these kind of open-ended tell me more types of prompts. And then you can use follow-ups. You said X, tell me everything that happened. Tell me more. What happened next? And using facilitators. If they're kind of telling you stuff, not jumping in, but just going, and letting them keep going. So you avoid interruptions as much as possible. Sometimes they're giving things and you need to pin down something, wait and pin down it later. So for instance, children can sometimes refer to their private parts using all sorts of different euphemisms or language or particular to them, and you're not sure like what part they're referring to. Just let them keep going. You can come back with a clarification question after, they've kind of petered out. You said the whoopee or something, and ask them more about that. It's same with names of people. They may say a him and a her and a she, and you want to jump in, but let them keep going as much as possible and come back and use these as clarification notes. So make notes and then you can circle back to these questions. While they're in the flow of narrative, let them give you as much of that detail as you can get from them. All right, I don't know if we have time for this last exercise. Okay, I have here, these are actual cases. So on the first page or 3 pages, we'll just do one, don't have time. So you can read them later on. One of these will take the child and one of these will take the viewer. Okay, so for the interviewer, you're just going to read the first page. The person that's playing the child will read the second page, which gives you a little bit more information. And then you can find practice doing these types of questions and trying to stick to the open-ended questions. These are all cases, real cases, examples of cases where. And in all these cases, it was psychologists that did the interview. It's something that happened. All of them happened within a school setting and were reported within the school setting, and the psychologist was asked to kind of investigate further. There are 3 cases. You can read the front and pick one of the 3 cases, and then the child, the interviewer only reads that bit, and then the person who's going to do the child can kind of go read more about it before they interview. Okay, we'll take about 10 minutes and then we'll wrap up, okay? Thank you. Thank you. gonna wrap up. We didn't get much time to do that, but you can take that and read them for all those three cases actually did come up. And just to let you know, if you read them later, so the case of Lily, there was something actually there. The child was being abused. In the case of Brian, if you haven't read that later. That's a good example of where a child can say something and it isn't necessarily the case that anything bad happened. So it was just a misunderstanding and with the child. It actually happened to someone I knew who's and then in the case of Jacob, that was a case that I had to deal with where here's a case of a child lying to their parents, but when we investigated, it was because they felt shame about being bullied, and therefore that's why they weren't. But once it was disclosed, then the adults were able to do something for it. So it's not always going to be about abuse that you might be talking to children that they might be not wanting to disclose about. It can sometimes be things like being bullied, for instance, that children feel a lot of shame around, and they may be reluctant at first to tell people about it. So those will give you some more. I think we forgot, but I'll maybe put it down to take home if you're. These are just kind of basically a cheat sheet of what we talked about how what are the best types of questions to use, what to avoid, and you can take that with you, and hopefully in the future it'll help jog your memory. And I'm sorry, that's really just a taster of it, but I hope it gave you some insights on how to interview children and what to keep in mind when you are dealing with sensitive matters. So thank you all for coming. Is any question? Yes. Yeah. Yes. 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 So you would start with something light, usually with all of them, but the degree that you would do that would depend also on the individual child. Always the individual child varies, right? And also the age of the child too, right? So your expectations of the degree of details you're going to get, how the child's going to be able to communicate, all vary by age, by having also, you want to start something like to get kind of baseline understanding of how they communicate and the degree. If you're operating in altering a context with lots of different languages and the child might be speaking multiple languages at home and whatever, you also need to get a baseline of like their language capabilities, all of that. So those first preliminary rapport questions are establishing rapport, but it's also giving you a sense of how the child communicates in that. And can give you some expectation of like the degree of how to, you need to keep your questions as simple as possible, but you may need to particularly be mindful of that with the younger children. Tell me more is better, because the why sometimes they struggle with, maybe an older kid, but the tell me more, they're more like, they'll come up with more details. A younger child's going to come up with more concrete details, whereas an older child may bring in feelings and things like that you won't necessarily always get in the younger child's report, but you'll at least get details. Hopefully, more details. Yeah. Yes. So I would assume that most cases the child is telling you the truth, because the fact is the most cases also that is the case. Where you might have some reason to believe the child is lying to you is, in the cases of where you have some other evidence to suggest something is different from what they're reporting to you, or you know some facts that, you know, are not. But I would keep an open mind and just take children's report on face value, because the more important thing is the maintaining the relationship with the child, keeping it open-ended, and the more that they feel comfortable with you, that you may eventually get a full disclosure or a truthful report, one way or the other. Only in small cases, children are telling false reports. They're very small cases, and usually with young children, it'll come to light often in the way they'll ask questions. They'll say things, and then they'll say, I didn't have time to give examples, but when I do a larger workshop that's over a few hours, I have one where the child actually was coached, and you see it in the transcript. It actually comes out in this 4-year-old because they're not able to conceal that. They talk about, well, mommy said I should say this, kind of, they actually say it. So I wouldn't be too worried about it because it's not that common. And in terms of your approach is, if you keep an open-minded and maintain the relationship, that even an older child who's might be lying, they may eventually actually disclose to you. There are no nonverbal cues. Again, I just was in Italy and I had to do a workshop that was over 2 days. On the second day, we spent on CBCA, which is criteria-based content analysis. This can help you detect sometimes false reports or truth reports. It's very detailed. It takes a long time to learn it. And even in the 2 days, I had to say to them, well, if you really want to learn this, now you have to do an actual course on it, because there's no way to learn it in 1 day. And I couldn't even touch on that in the really short time we had now. There are some techniques that are based on verbal, but they require a lot of training, and nothing's foolproof. They just give you a sort of indicator of. Yeah. Was there a question here? Oh, yes. Mm-hmm. So I would think, like, so 2 things. Pathological liars, when they're adults, they'll often come to the clinician. So they often don't want to lie, but they just can't help themselves. So they'll present themselves to the clinician saying, help, I don't know, I can't stop myself. So you'll see them present that way. In the children, sometimes parents do that. You need to investigate more, because sometimes the children is lying problematically. Sometimes it's the parent's perception. So you just need to investigate more and find out what it is. And then you have to figure out, sometimes there's some explanation. Like, I had a child that was lying. The mom complained the child was lying. And then we investigated. The child was always telling fabulous stories about things she hadn't really done. And she was doing it always when the mom was engaging with the older sibling. And the younger sibling was just feeling like they weren't getting enough attention. So they started telling fantastical stories to get more attention from their mom. And once you saw the root cause of that, but the mom wasn't perceiving that. She was just perceiving her second child was problem and annoyed with them all the time. So then you can help the parent, you can help the child that way. So you need to investigate what the lies are, what's the context, because sometimes it's a bid for attention. Sometimes it's an indicator of other things, right? So, yeah. Yes. Oh, thank you. Yeah. Mm-hmm. very good question. Trying to answer it these days and the data that we're collecting. What we know is that lying can be a symptom of other conditions. So like, for instance, it's a symptom of conduct disorder, oppositional defiant disorder, psychopathy, anti-personality disorder. It's also some people who have callous emotional traits also can lie as well. So there are many ways where lying may be implicated as part of another disorder. Pathological lying is suggested by Curtis Hart to be its own thing in itself. But yes, it has associated with, especially psychopaths, they will lie and they'll lie without remorse or feelings of guilt. In this case, there may be temperamental traits that are, leading them to a certain profile of behaviors that will include lying as well. We haven't got any evidence to suggest lying in itself is temperamental trait because it's a ubiquitous behavior. Most people tell occasional lies, but it's just an occasional behavior. And in that case, it isn't tied to personality. But in these very extreme cases, it may be tied to these personality disorders.
Thank you so much, ma'am. That brings us to the conclusion of this insightful workshop. On behalf of everyone present, I extend our deepest thanks to Dr. Srivastav, who joined us in the beginning of the session, and also to Dr. Talwar for enlightening and thought-provoking workshop. And a special thank you to our audience for engagement and presence. Thank you, everyone. Now, I would also invite Miss Ria ma'am here to felicitate our guest speaker. Thank you so much, Dr. Talwar, for this wonderful workshop.
So, ma'am, should we start? Yeah. Okay. Good evening, everyone, and a very warm welcome to the workshop on bridging training and practice in clinical psychology. It is my honor to introduce the chairperson for this session, Dr. B.N. Rupesh Sir, an additional professor and a consultant clinical psychologist in the Department of Clinical Psychology at NIMHANS. He holds an MPhil and PhD in clinical psychology from NIMHANS, and his specializations include clinical psychology, neurology, and psychiatry. Next, we also have a panel of speakers. Our first speaker will be Dr. Ravikesh Tripathi, who is an assistant professor of clinical psychology at NIMHANS and serves as the Joint Secretary of the Council of Professional Psychologists of India. He holds an MPhil and PhD from NIMHANS with research expertise in neuropsychological assessment, cognitive functioning, and digital mental health. With over 60 research publications and 400 plus citations, Sir has made notable contributions to the field of psychology. Next, we have Ms. Shannon Samuel Ma'am, who is a dedicated clinical psychologist currently practicing at St. Stephen's Hospital, Delhi, where she provides psychological assessment, therapy, and emotional support to individuals across diverse age groups. Her work reflects a strong commitment to improving mental health awareness and promoting holistic well being and compassionate, client centered care. Ma'am has been actively involved in addressing emotional, behavioral, and adjustment related challenges, helping clients build resilience and emotional insight. Our next speaker, Ms. Rupangi Shah ma'am, is a passionate clinical psychologist and the founder of Aram Mental Wellness. With over 5 years of experience and advanced training in CBT, mindfulness, and Gestalt techniques, she works with adults through a humanistic and compassionate lens. She is also a university educator and workshop facilitator. Ma'am is currently pursuing her PhD in clinical psychology at NFSU, driven by her mission to make therapy more human and stigma free. Next, we have Ms. Avni Vasani ma'am, who is a clinical psychologist with an MPhil in clinical psychology and an MSc in neuropsychology. With over 9 years of experience, she has worked extensively with individuals, couples, families, helping them navigate emotional, behavioral, and relational challenges. Known for her empathetic and collaborative style, she supports clients in developing insight, resilience, and healthier coping strategies. Without further delay, let us begin the workshop, and I now invite our panel to please come and begin the workshop.
Good, sir. Yeah. So, as we all know, that clinical psychology is a professional field. It deals assessment as well as treatment in regard to mental health. As far as professional practice is concerned, in India, RCI is regulating the clinical training and teaching program. This citation is taken a bit, this is not recent one, it is 2023 citation. And as you can see, several institutes providing clinical psychology degree that is recognized by Rehabilitation Council of India. You know that Rehabilitation Council of India is premier body which regulates training and teaching in clinical psychology. So with this table, it is very clear that private, universities and institutes also now emerging very rapidly, and we have 37 institutes so far as per this citation. But now, as you know, that we are changing the nomenclature, and it is going to become MA Clinical Psychology or M Clin Psy. We don't know yet what would be the exact one. When someone receives their professional degree, MPhil degree, and after that they go outside and they start practicing. Several difficulties they face during their professional journey, and this workshop we are going to discuss those difficulties which we encounter when we are going to practice in real world. One thing which I have noticed when I started practicing as a clinician as well as teacher or professor clinical psychology, several institutes are not equipped with the infrastructure, be it clinical infrastructure or physical infrastructure. Also, patient cares are not available for the teaching and training. That I have seen. There are huge difference from one institute to another institute. But we assume that these institutes, 37 institutes, they are providing at least minimum training to their students, and they are as par and they are ready to go and practice outside. Now I have my three colleagues. They are going to share their experience of whatever they have encountered in these last 5 years. I'll request Shinon to come first and discuss her professional journey during the past 5 years.
Thank you, sir. This is a workshop, so we've tried to keep it very, very experiential and practical, something that we all as speakers, as professionals have witnessed. So I'm going to basically talk about the professional transition from completing your MPhil and when you actually start with your practice, everything that you go through. Just want to start with a disclaimer. I think this will set the course of our presentation. Um, the disclaimer is part evidence, part experience, because research on this transition is scarce, but the struggle is not. The goal is to name what everyone feels, but few papers discuss. So this is the heart of our workshop. Um, so while I was thinking about, what are the practical challenges that I as a professional have faced, these are a few things that came to my mind. First and foremost, stepping out of, your zone of proximal development, just referring to Vygotsky over here, how there is this sudden loss of supervision and now you're completely on your own. And then something like how Maslow would call it, Maslow didn't warn us about the bottom of the pyramid. Salary and monetary concerns in our field, it's a real time issue. To the extent I met my MPhil junior like today itself, and the first thing she asked me, where are you practicing and what is the salary like? That was the first question. So find it very relevant. The administrative and job related realities are very different from what we experience while we're on the training. And yeah, this is also very real. Like how Rogers puts it, that moment of incongruence, that so called imposter syndrome. Am I capable of delivering the care which I have been training to get? Now I'm on my own, and am I ready to do this? Last but not the least, something again based on what Rogers says, entering Rogers' fully functioning mode, one client at a time, the absolute clinical independence that you experience when you step out of your MPhil or clinical training and into the real world. You also have the freedom to shape your practice the way you want to. At the same time, the challenges are real. So,
maybe we can look at the basic frameworks which all of us can practically consider at whatever stage you are. This is considering you're a novice professional, just completed training, or you are in the process of figuring out where do you fit in the whole clinical scenario. This is something that stemmed from our brainstorming about the workshop, and we've tried to structure it in that sense. Where do you see yourself working in a pure hospital based clinical setup? Do you see yourself setting up your own private practice? Do you see yourself getting into a combined role of what we call as a academician plus a clinician? Do you want to engage with the community, or you completely want to switch to a very corporate perspective? So we've tried to summarize it in some basic headings, what the setting looks like. Of course, in a hospital setup, this is very similar to what we do in our MPhil, but depending on which kind of hospital you're working with, mostly it's a multidisciplinary approach. Of course, you are engaging with a lot of complex cases. There's a lot of overlap between administrative responsibilities along with your clinical roles. And this is a classic setup which you see in hospitals like NIMHANS, AIMS. These are government setups, but also in private practices. It varies from place to place, city to city. But this is roughly what it looks like. Setting up your own practice, we have an entire section of our workshop that's going to focus on this part. So, not getting into the detail of it. Definitely things when you talk about the academician clinician role, it's about obviously pursuing your studies further and looking for a place where they do training for professionals. So how do you engage yourself using the scientist scholar practitioner model? And of course the details are in front of you. The other last two approaches are not very common, but we still feel that right now opportunities are opening up in different sections and it is worth considering. So you can just take a look, have a word, see, think, talk about it, and find where you fit well as a professional. So, talking about the hospital based clinical practice, I myself have been in a core hospital based setup since the time I completed my MPhil. And there are some challenges and some takeaways that I've had, which I've put them together in this presentation. I'm not getting into the detail of it. These are some basic things that we already know. We work in a multidisciplinary team in a hospital setup. We are following the scientist practitioner model. And of course, a biopsychosocial approach is something that we are focusing on. These are some basic responsibilities that one can look at as a hospital based setup clinician. Okay. There is clinical assessment therapy, which is the basic role that we are trained to do. Licensed psychiatry, I don't know how much exposure different MPhil programs. I think there are some which do give you that option of having a lot of license. Training and supervision, again depending upon the hospital setup that you're in, but these are the basic roles and responsibilities that one can look at. Generally we are kind of aware, but the reality is very different from what we hear about while we're in the process of training. There are certain setups around which are focusing on these scenarios. I've put in some examples of what looks like in the Indian context. Of course there can be overlap in many ways. We're talking about NIMHANS, how the whole setup is very, very elaborate. There are specialized units and they're focusing on different kinds of work. At the same time, in AIMS, we have again a de-addiction unit. There's a separate unit that focuses on therapy, OPD. It's very, very systematic. I'm currently working in St. Stephen's Hospital, and ours is a very multidisciplinary approach. Psychiatry is a very small part of the whole hospital, but the reason why I've mentioned it over here is we do a lot of liaison work. So we're working very actively with IVF patients. We're working very actively with the emergency department. Patient comes into medicine, and if a psychiatric issue has been identified, so we're always running around, and that's the nature of work that I've practically witnessed. Again, CMC Vellore, I've heard that they are also doing a similar kind of model is being followed, and I'm sure there are several hospitals who are taking up that approach. Training and supervision, again, if it's a RCI run hospital, if they're running RCI regulated courses, it is a mandated thing and they're taking care of these setups. Okay, so came across few researches that talk about challenges that are witnessed very commonly in practical
thing. Again, this administrative role, this is very ambiguous because none of us are trained to handle it. But the moment you become an independent professional, you get into the practice, you are responsible for managing many things, which either your supervisors were taking care of, or it was, something which was not at the top of our heads. But this becomes a very overlapping thing, because where does the role of the psychiatrist end and where does the clinical psychologist steps into the picture? It's something that you have to figure out on the job, depending on the setting that you're at. Documentation burden and medical legal accountability, something very, very important. I'll try to take it up as I conclude this section of the presentation. And of course, burnout, because the caseloads, again, are very high in hospital setups. Of course, depending upon the setting, because like I mentioned, you're not just taking care of your psychiatry OPD, there are the departments, referrals. If you have an IPD, that's an additional responsibility. And if at all your hospital has a nursing college or somewhere, where they'd like to pool in their resources from the psychiatry department, you can be prepared to even, extend your duties in that direction. So I'll just quickly just focus on the most important things, but I don't think this is limited to clinical practice in the hospital setup. This is something that you will witness also in private practice. AI is very important aspect of psychotherapeutic work that we are doing. The reason why we've brought it up is we feel that it has and it will shape more of clinical work that we are doing, whether it is the patients, and this is completely from how patients interact with AI, and they come back to you in therapy. They are expecting, they come up with a preformed diagnosis and they're expecting you to verify it. Their expectation is like ChatGPT or these other AI tools, you'll also be available 24/7 responding to their messages. I've faced certain issues in this area. Of course, seniors have talked about setting boundaries, not sharing your contact number, but the reality of the clinical world is very different, because you also have to sustain your patient and be there for them. So this is like, these are some shaky waters and you have to navigate around them. So these are some very practical things that I've witnessed in my practice. Comparison with AI response, this is just very frustrating when it happens in a therapy session. But if you're practicing, you know that this is something that happens quite a bit. Patient will say that I had this conversation with ChatGPT the other day and they said this, and now you're saying the absolute opposite of it. Where do I stand? It, of course, jeopardizes the therapeutic authority of the therapist. And often there is something like emotional displacement that happens, where clients develop reliance on AI more than the therapist. Those boundaries, those concepts are very, very vague. And recently, if we've looked at the news, we've already seen what has happened. So the situation is very intense. Of course, I've picked up the aspect which is a demerit of the whole situation. There are merits and there are aspects which are very, very beneficial also. But just focusing on these challenges can help us to be more focused in our clinical practice. So lastly, I just want to conclude with a few things. When we're talking about hospital-based role and how you transition from being a trainee to working as a professional, I think the first and foremost thing is to remember the ethos of your training, like how we've been all trained to practice evidence-based approach. This I'm saying in the context of the sudden responsibility that comes when you start clinical work, because documentation is very important. The hospital where I work recently, we've shifted our entire documentation from paper to a computer-based system, which I feel has already happened in most places. So our detailed therapy notes, which were 2 pages, 3 pages, have come down to almost a paragraph or so, because there is time paucity and how much can you type and put. So these are some challenges that you face. Along with that, it is very important to be true to what you've learned. But when reports start piling up, the quality starts getting compromised. I've personally struggled with it. So working smart is very, very important. Multitasking is very, very important. And to continue doing it, it is very important for us to stay connected with our peers, keep in touch with senior superiors, take help whenever it's needed. Most important thing, very important, to keep upskilling yourself so that you know what is happening around you and stay relevant in the field. One very important thing that Ravikesh sir used to say when we were doing clinical practices, that patient is your best teacher. Instead of focusing on just reading your book while you're in the hospital setup, listen to what the patient is saying. So I have experienced another level of this because now it is not just about listening to the patient, but also to the patient's informant, which happens in a hospital setup, unlike in private practice. And this I'm saying from the context of medico legal cases, which have started coming very regularly. And it's not just limited to government setups now, at least in Delhi, they're coming to the private setup also. So take the advantage of the multidisciplinary team which is available for your psychiatrists, your social workers, whatever people you have along with them. It is best that the person goes through all those channels. So utilize them, know that that is the strength of a hospital based clinical practice. And last but not the least, the navigating the monetary realities, it's very very important. So of course it's a cost benefit game. There are certain gains, there are certain losses. So just see where you find yourself in the whole process. Thank you. So this is from my side, and I think if the last bit stands out for you, this is the next portion of the presentation that's more helpful. I'll now request my colleague Ms. Rupangi to continue.
Thank you, sir, and thank you, Ms. Shannon, to set the tone. My portion is a little different. First, how many MA students here? Any MA students here? No. How many MPhil trainees here? Okay, one student MA. Okay, MPhil students here? Okay. Practicing psychologists? Rest of you. Okay. So, I'll briefly share about my work experience. After finishing my MPhil, I joined National Forensic Sciences University as a faculty. I've taught there for 2 years, and then I started my private practice named RM Mental Wellness, which is in Ahmedabad. Now, the reason I'm sharing this is because I have both the experiences. One, teaching, very different. Another is a solo private practice. And using that, I'd like to share the findings. One, any of you planning to do private practice, your own practice after your MA or after your MPhil, after a year of practice, maybe year of working somewhere and then having your own clinic? Anyone? Okay. So, whenever you wish to, please ask yourself these questions. How confident am I to start as a private practitioner? The answer will always be I'm not. It's always going to be that. But of course, then objectively assess it. How much money do I need or I want to earn? Now, let's be very honest. When it comes to this field, no, psychology, somewhere in my 7, 8 years of training, all my life, I've never had a single faculty, any one person telling us about how do you earn well. In fact, the worst thing is this is stigmatized in our community. Somewhere, those who talk about earning money are seen as, oh, you're not a good practitioner. You don't want to help people. All you're focused is on money. Ever heard that or ever faced that look that, oh, you're not interested in patient care but money? But why not? Don't we have to run our own houses? So, just another question. We'll be talking about this again. But ask yourself, how much money do I need or I want to earn? Why? Because job or academic setup has certain amount of earning for sure. Private practice, like any private practice or a business, is I mean, never ending. It can go as much as you want it to go. Ask yourself your values, personality, and choices in life. How much does it match with, establishing practice from zero? How do I want to feel at the end of my work day? Because I'm going to share how it feels like working in a private practice. And in 5 years, how do I see my practice evolving? Whenever you wish to start, please ask yourself these questions and consider these factors. These are very practical factors. Private practice involves, so in lay term, how I say is, I am the peon, I am the accountant, I am the receptionist, I am the clinician, and I am the supervisor. At least in initial 2 to 3 years, unless, I mean, till you have a larger team to function, you have to do everything. Yes, it will give you good flexibility, good money, but extremely disciplined scheduling because you have to manage all of it. Job will have steady income, less responsibility, limited flexibility, but lesser operational stress. So if you are in that phase of your life that I've studied enough till MPhil, now I want to relax a bit and not go here and there, run here and there, you can think of picking up job for a while. See, when I say job, I don't mean that in job you don't have to do these things. You still will have to. But the comparatively, it will still be lesser than your own practice. And this is how it looks like. As I mentioned, all of it you'll have to do. Okay, so you have to understand that, are you, your personality, does it allow you to manage all these things? Because in private practice, it is not just your therapeutic skills which is important, but these skills you will gradually learn, but you have to have that eagerness to learn. Now, the classic thing which I always talk in my workshops, business mindset versus social service mindset. I know this word also. Once I did take this one full day training on this entire topic, and there were my own teachers sitting there. My master's teachers were sitting there, and they were all looking at me like, what kind of word are you using in a psychology department? Business mindset? And I defended it saying, see, I'm a Gujarati blood, and I can see sir smiling. So it comes naturally to me. And it has to at some point. When we run, when we think of only social service mindset, it is always driven by compassion. I will offer free sessions, sliding scale sessions, or I will not take charges for cancellation, feeling guilty for charging. So all of it is emotionally very rewarding. I don't disagree. After a point, it is very draining. Okay. However, a business mindset, all of these things are there. Yes, you can provide sliding scale slots and yet earn good money. Yes, you have to be compassionate only when you are sitting with your client. However, you are seeing your service as a valuable service. Okay. You set clear fees, boundaries, you focus on growth and visibility, sustainable, you feel sustainable and confident. Every now and then, you don't have to meet people in conference and ask, how much are you earning? Is there any better job vacancy somewhere? Okay, so that's a business mindset. Again, research, quite a decade old research, but even the latest research is quoted psychologists earning very less. And hence, I wanted to take 5 minutes. I wanted to talk about the right marketing strategies. Now, this is something again not taught. A single paper of marketing never taught in psychology, right? So, few things I have figured out from my for myself in last 3 years when I shifted from a teacher to a clinician thing. One, meet people one on one. How many of your relatives know what you actually do? I'm not talking about the title psychologist that they know. Very fancy thing, they know you're a psychologist. How many of them know that you can also work on habit building? How many of they know that, oh, if their child has screen addiction, they can talk to you about it? How many of them know? May not. Okay. So what happens is we are confusing these days. We are confusing marketing with only social media marketing. You don't have to dance every time and shoot reels for your publicity. No, no, don't think it is limited to that. Okay, meet real people one on one, your neighbors, your friends, your school teachers. Do they know that if there is someone in the class who is not able to retain well, they can refer them to you? You may be sending them a happy Teachers Day message, but they may not know what are you doing. Okay, so try to have those conversations. Visibility is the key. There are so many practitioners, and unfortunately, half of our business, who are eating half of our business, motivational speakers. I would not refrain myself from saying that there was a point of time I hated all of them, just because of this fact that, okay, you want to do everything, you want to treat depression, anxiety, everything, spread toxic positivity, and nobody is going to come to us. But then it is not their fault, it is our fault that we are not telling lay people that we can talk about these things, we can help you visualize and learn to deal with your fears, we can help you with that. So it's our responsibility to tell lay people and be visible. Again, being visible does not only mean being on social media. Yes, it is a larger market these days, but There are other forms of visibility too. As I said, talk about it everywhere. Try to slip in that conversation wherever you are. Okay? Be it family functions, be it relatives, be it your friends' parents, wherever, everywhere there is some conversation around behaviors, and we are experts for that. So, another thing, cold emails, thoughtful outreach. Please do not wait for people to come to you. People are not going to come and ask you that, Mr., would you like to come and take an awareness session in my hospital or in my school? No, they're not going to come and ask. They don't know you exist. You'll have to send emails, make brochures, make cards, contact again and again, find a loophole in the system, meet, go reach them, wait 10 times, be rejected 11 times, and then get an appointment and then prove yourself to be able to get another program. That's the process. Very tedious, yes, yet very, very rewarding. And yes, go beyond sessions. So, whomsoever is planning to practice independently, even after a year, 2 years, please remember you can never sustain only through sessions. How many sessions can you take in a day? 5, 7, 8, 10, maximum 10. Let's say even if you're charging 2000 per session, you cannot have 10 sessions every day for 2000. So still, how much will you earn then? You'll also have to think of other expenses, right? So it can never be one model of earning. Think beyond sessions. And when I say think beyond sessions, host transformative workshops, lead mental health awareness initiatives, initiate, don't wait. Please understand, people keep saying that there is mental health awareness and stigma is removing. I mean, yes, it is, but the pace is very slower. We still are in a place wherein we will have to go and sell ourselves. Anybody watches Shark Tank here? Anyone? Okay, thanks. So it's you have to have your pitch. How am I going to pitch? If it is an academician, this is how I can offer student wellness program, teacher wellness programs. If it is a hospital, I can talk about doctors training on mental health. If it is this setup, I can go and talk about it. You have to have your pitch ready anywhere and everywhere you go. Right? So initiate, don't wait, actively network and follow through. The conference, please ask yourself tomorrow evening, how many new people did you meet? How many contact numbers, email IDs did you exchange? How many new LinkedIn followers? This has to be there. It may be awkward initially. It may really be awkward initially, but trust me, you cannot sustain without it. Okay, unless you are from a premier academic institution of your country, you are not going to be known. You will have to prove yourself. That's how it works. And yes, map your network strategically, be it psychiatrists around your city or the physicians around your city. You need to have these things prepared before you actually complete your MPhil, if at all you're planning to do your private practice. Okay? And yes, if at all, after 2 years, 3 years, if money is something that drives you, along with creating larger impact, think of growing beyond solo practice, think of leading a team. It is also rewarding in its own way. So after a year of solo practice, I felt that, okay, I may not enjoy seeing patients only all my life. And hence, I started workshops for psychology students. So my teaching need is fulfilled. Hence, I now have a team of 10 other psychologists working with me. And then, supervising them. So the caseload, I have a lesser caseload, only 2-3 sessions a day, and more of administrative management tasks, which I feel, again, referring back to the personality I was saying, I feel I am good at it and I like doing it. I like management as much as I like psychology. So it blends well. So think of it also because, again, solo practice also, even if you see 100 patients a month, think of earning. It will be limited. So if you want to grow, expand, you'll have to have a team and few, like very few, just dropping some pointers. You can note it down and use it later. Think of getting GST registration, MSME registration, apply for bids and tenders in GEM portal. So there are a lot of government tenders that are uploaded for Sarva Siksha Abhiyan, teachers training. Lot of things are there which we are not aware about. Nobody talks about it. So please but you will have to have GST, MSME registered for these things. Right? So think of it in longer run. Partner with corporate schools for collaborations. Again, patient only waiting for patients to come, it it is never a good ongoing flow. You'll have to have multiple collaborations to run your unit. diversify income through institutional tie-ups, as I mentioned, strengthen brand via official partnerships and certifications, and move from clinician to a leader role eventually if you wish to, if you feel that is something that suits your personality. So thank you. That is it from my side. Um, I'd like to invite now my colleague, Ms. Avni Vasani, who will talk about once you have the client. I was talking about how to get a client, and now once you have the client, how to retain them. Thank you.
Hello everyone. My name is Avni Vasani. I have been practicing in a three-tier city, Jamshedpur, Jharkhand. It's a very small town, so I'll be mostly be talking about how we can start a practice and how we can retain clients in two-tier and three-tier city, and where only online practice is something that we are going to opt for. So what we are going to do after you have set up a practice, after people have started knowing about you, now we are going to start with how do we handle inquiry calls. So in the initial days of my practice, what we used to do is whenever I used to get a call, I used to tell them, I used to give them a brief introduction about what therapy session is going to be, how we are going to start. I would understand their goals. I would form goals with them, and then we'll take a step forward. The initial call would last for 15 to 20 minutes, and then we'll take it forward. We won't just start with the session. The initial part is to find a place where I can build a rapport. After the call is done, after I have made a call, after the patient or the client is aware of my understanding or whether they get along well with me, then we'll come to the next part of it. Once the session is started, in the first or the second session, we usually share an informed consent. Now, the informed consent has to be very individualistic. We can't use the same informed consent for everyone. If a patient is a child below 16, if there are suicidal ideation, if there are self-harm thoughts, then the client form or the intake has to be different. If you're practicing in a different city, not everyone would be knowing English. I have a form in Hindi and English both, because the local people are more comfortable with the language. So they have to read the form in order to sign it. After that is done, in the initial stage, I didn't have a large staff. I didn't have someone to take my appointment. I didn't have someone to give a retention call. Nothing. It was just me who was doing everything. So what we did was I started with Google Calendar, something very basic, something that I can share the link with my client, and I'll also have a reminder. If in the initial session, if I am missing out on my appointments, if I'm continuously rescheduling it, then it would be unfair on them, and it will also hamper my own self-image. So this is something that we'll start in the initial part. You have to do it all on your own. We are not practicing in a hospital. So what you have to do is the initial phase has to be something that you have to be very stringent about. Your form should be ready, local form should be ready. If there is something that you need to provide to them, that has to be clear. If you have to share an invite, that is something that has to be very, crisp and clear in your mind. Also, as many apps as you can use, something that we can use daily, something that is very easier to use. Don't complicate your practice a lot. This is something that I have learned in the initial phase. After that, what we are going to talk about is, as Ms. Rupangi has already mentioned, I am not so monetary inclined. So sliding scales and cancellation policy is something I do talk about. Sliding scales I do provide, at times also pro bono session, but it is something that has to justify my value system also. So that is something that I am very particular about. I do offer pro bono sessions, I do offer sliding skill, but that is something that I feel that I'm not taken for granted. My practice, my time, my understanding of a patient is being valued and appreciated. When it comes to cancellation policy, medical emergency, definitely we can taken for consideration. There is no, and even if it is repetitive in nature, somebody is falling sick or a family member is falling sick, we can't be so inhuman. But it is something that they also have to understand, that I have booked a slot for them, so I won't be taking session during that time. So my time has been already been invested. So if it is a repetitive practice and I know the other person is not being considerate, then I need to rethink my cancellation policy. So what I do is, once or twice I let it go. Medical emergency, definitely I'll accommodate. But if it is happening on a daily basis, either I'll charge half of the money, and whatever fee I have taken, 50% cut I will give. Or if they're not doing it before 24 hours, if 5 minutes before the session they are telling me that they have some work to do and they won't be able to make it, then I'll ask them to reschedule it. It is not only about the monetary part of it, it is also about them respecting my time. So this is something we have to be very comfortable with. Understand your value. In the initial session, especially, you'll feel that, oh, I'm charging money for doing nothing. But you have to justify it to yourself that your time is being invested. So you have to be a little assertive in your own mind. So this will only come when you know about your work, you know about what you are investing in a session. Then comes documentation, one of the most integral part of the session. Now, what we have been taught is like, you don't take notes during the session because it becomes a very mechanical transactional process. So I do take important if they're mentioning certain kind of names or if they're mentioning certain things that I need to, like, I will be forgetting. So I'll take a brief, like I'll make a pointer out of it, but I won't scribble in my session. It looks very like, then it becomes very not one-on-one. The person doesn't feel comfortable. But after the session is over, I'll take good half an hour break. I'll write down the notes. If I have to share something with them, I'll provide them. The summary of the session is very integral. Why? Because in the next session, I don't want to forget any important details. And this will also help me with the rapport building. If my patient is aware of every single detail that has been mentioned in the previous session, they'll be able to regain that trust in me that my therapist was completely attentive while we are taking the session. Sharing the session summary, I usually do. I prefer sending it over a mail rather than WhatsApp. So I have something to share with them. They'll have something documented because it is a very subjective field altogether. We need something concrete to hold on to. If there is something that I need to some task to share or some reference to share, I also share it after the session is over. Once that is like after that is completed, if there are any legal implication which you will get, if there is something that they would want to know, if there are some suicidal ideation cases that will get you into some legal hot waters, so we need to have concrete evidence for that. So in that, we can't miss out on any important details that are present during the session. Feedbacks from the client, what I do is I take bi-weekly feedbacks, or I take feedback after 4 to 5 sessions. So if there is something that they would want me to understand in the session, maybe I'm going too fast, maybe I am being little more like assertive on them, or they would want me to take things slowly or not provide them with a lot of tasks, this is something that I need to tell them openly, that you can say whatever you want. This is an open communication, and also tell them that I might not always be correct, my process, my thought will not always be correct. So this is something that you have to understand, and you have to have a very transactional relation, very liquid relationship with me, so I'll be able to understand you better. Then post session reflection. The first year, it is so important because this is the time when you will define yourself as a therapist. After the session is over, what do I feel? There are times that I get very agitated with the patient. There are times that I feel that I haven't done enough in the session. So then what we do is we start terming our sessions at good, bad, neutral, and with all the parameters that are self built. It is not on the patient, it is not something that we have read somewhere. But if we feel that we have completed or we have fulfilled a goal, that means the session is good. It doesn't work that way. Even a very insightful thought in the session by me or by my patient reflects on me having taking a good session. There is no parameter, and if you are considering that parameter, that until and unless all the goals are taken care of, there will be some magical thinking, my patient will immediately feel good, it doesn't mean that you had a good session. It just means that you have very superficial expectations from yourself as a therapist. So understand your parameters, challenge yourself. At times, when if there is a patient who would be speaking very, I have my drawback is when somebody talks ill about animals, and this is something that I have understood, that I get very agitated, like if they don't take care of their own pets or something like that, or if they tie them up, I get very agitated in the session. So this is my drawback. So I have to understand that either I have to refer that case or I have to be very clear in this session. But I can't torture myself in the process. It will be unfair to the patient, it will be unfair to myself also. So understand, what do you feel after a session is over. If there's a lot of irritation, if there's a lot of agitation, if you feel angry, if you feel that I haven't done enough, rather than reflecting on just what happened in the session, also understand if it is triggering you in certain way. So this is something that you can understand also in your supervision process when you're speaking to your supervisor about the session. Then making online sessions better. I have only been taking online sessions from the very beginning. So all I have done is like I have made sure that I have proper connection. I can't disconnect in between the call and say that I didn't have network, so I'll start again later tomorrow, or we'll schedule it again. It would be very unfair on the patient because the client would be in middle of a thought and suddenly my network gets disconnected. It will be very unprofessional of me. Creating very helpful homeworks and follow-ups after like a week or so, checking up on them, understanding if there's something that they have to reflect back on. Provide them with that space that they can reach out to you, they can talk to you even after the session is over. You don't have to give them continuous support. All you can do is that this is the space where you can speak and we can continue in the next session. Maintaining a ready doc techniques. So in the session, what I do, if there is an assessment which needs to be done in the session, for example, BDI or HMA, I'll do in the session itself. I won't give them as a task, but if it is an elaborative test, for example, SSCT, then I'll ask them to complete it and then I'll kind of score it for them. But as much as you can do in the session, it would be better for both, for you to understand through their body language and their non-verbals, and for them also to take care of it. So whatever you are comfortable with, please provide them with those documents and keep it handy. Don't look for it in between the session. It looks very unprofessional. Now, gradual learn to, there are few patients, there are few kind of disorders that you will be uncomfortable with. Understand your limitations. It is not possible for everyone to be comfortable with all the kind of disorders that you know. It is not humanly possible. For example, for me, any form of pet grief therapy is something that I'm not comfortable with because it is going to trigger a lot. So it would be unfair, it would be non-justifiable for myself also to put myself in that position. So I understand whenever it comes with this goal that we need to go through some grief therapy, I'm not comfortable. So I'll tell them that, I would like to refer you to someone, but I won't be able to justify you in the session. So understand, but this won't happen with your first session. After a while, after taking the similar kind of sessions, when you're uncomfortable, then you'll know about it, that these are the cases that I won't be able to sit for, or it will affect me a lot after the session is over. This doesn't say that you are any less of a therapist. This just says that these are your limitations. It is always better to understand your limitation rather than put yourself in position where you have to challenge your core belief system. Last and the most integral part of it, as a therapist, as an individual, focus on learning, focus on unlearning all the old patterns. As I mentioned, that I should be knowing everything, I should be a particular kind of therapist. We have all read our books, we have all taken our sessions, but understand your limitation and your individual personality in the session. Relearning about yourself also. Like in the session, you will learn a lot about yourself. After a session is over and when you are able to reflect back on your own behavior, you will understand there are a lot of new things that you're learning about yourself, about the society that we are staying in, and also the culture. So this is where we come. Every expert, whoever it is, I'm still in the process, was once a beginner. We started with it and then eventually will somewhere reach. Okay.
Please sit, please sit. No, please sit, please sit. No, it's here, it's here, it's here. Okay. So, masters, people, temples, tolerance.
So,
one of the reasons that we do an MPhil is also because of the at least the minimum amount of guaranteed training and specialization that we get. But even after an MPhil, it is not possible for any newly minted clinical psychologist to know everything. So supervision is important, but there is no formalized or structured process or rules or regulations set up for supervision for clinical psychologists or for any kind of counselors in this country. So what do you recommend as professionals in this field? What is the way forward for that?
You want to point out to anybody or
Generally,
Peer supervision is available in most of the institutes. It is available. Yes, recently evolved institutions are maybe they are not having well established system, but this is one important area where we have to do systematic work, and peer supervision need to be available. If someone want to discuss something, or supervision based discussion need to be available for the trainee therapist. I think that need work need to be done. I don't know RCI is going to support in that direction or not, but as a professional clinical psychology society, we can actually evolve those systems. Another system which I think is lacking is referral based. Many patient we are not comfortable. Like let's say I am comfortable in older adults client. If someone who is having antisocial traits or personality related traits, maybe I'm not comfortable. So there should be established referral based system. If I'm not comfortable, then where should I send this client so that they can get appropriate help? So these two things, I think we need to evolve mechanism and system to address those issues.
So, Joel, one thing I feel there are a lot of again private practitioners who do provide supervision and which is very helpful because not just right after MPhil, honestly, after 5 years of MPhil also, there are so many cases, certain very different kind of cases which are not seen in government hospitals or at least where I was trained. So then you can get case specific supervision also, though it may seem a little expensive initially, but it is worth it, is what I have felt in my supervision. And as Sir mentioned, there is always peer supervision possible. So, your own MPhil batchmates, you can have that informal group wherein probably once in every 15 days you're meeting for an hour discussing specific type of concerns or specific cases. So something of that sort is available. You just have to find out on LinkedIn, stay connected with people. There are so many people providing supervision. Just one thing I'd like to add. One thing that really helps in this is to be in a multidisciplinary team. So when you have other seniors or colleagues, it becomes very helpful. So it is worth considering that when you get into practice, first you find a scenario where you have other professionals who can act as supervisors for you, or just even case.
There's a lot of WhatsApp. There's a lot of WhatsApp group around. Okay, so if you can join.
But is there a way to like, because there are so many people doing these things now that I think 5 years ago supervision wasn't that popular. Also now there is people offering supervision left and right. Forgive me for being crass about it, but then how do we understand, who do we get the real insights from, who do we get the real training from?
Help me. or you ask other people, get their feedback. Second, sometimes it has to be trial and error based. You have to, even same supervisor may not be a good supervisor for all kind of cases. So in that case, eventually you will learn that okay, for these kind of cases this person is a good supervisor, and for these kind of cases I can ask this other supervisor.
As reflected, like how we go with the therapist also, it is most of trial and error basis. It depends on like how well we connect with the therapist. That doesn't mean a therapist is bad. That simple.
Right. Yes, I also feel sorry that there are so many supervisors and don't know how to genuineness of those. So system has to create certain maximum governance. Still, so far don't have that maximum. I think in future, certainly in this that some of the actions will don't think I'm the right person to say because I'm in the government sector of the or institutional sector. So these people will be better to say. Hey, sorry. So yeah, this is a good thing that saying that we don't have any terms of course, like how to supervise others. This time it will feel in a way some institution when doing PhD is called junior consultant and then author or faculty consultants they do. But apart from that, outside, not there. Other thing is in terms of training or certification, it is not there. Whatever the qualification. Yeah, that is in a way it can take up, but it becomes challenging because it's not a degree. Who is on the course? So, okay. For example, in that particular, we do some workshops, for example, to take PFT or ventilation based therapy. And so they have certain levels, level 1, level 2, level 3. Later on, it comes to the category right around the way. So that private is possible, but in the terms of institution wise, it becomes difficult. Not impossible, but because the larger societal or political second question. Again, after some time also it becomes difficult. Like, who can say who's better? Who can do better? So a lot of issues are there. Not impossible, but like in terms of institution setting, it takes long.
How do we know when it's the right time for us to start our own clinical practice? Like ma'am even mentioned a few questions like, are you confident or are you ready? Personally, I feel that the answers to those, no matter how many years of experience I have, will always be no. So how do you know that you're actually ready? Also, side effect. Side effect.
Is no? Can you hear me?
Yeah.
Then it's okay.
Honestly, there is no definite answer to this. There's no formula, X amount of experience and then you can. If you're underconfident, first thing you can do is like a part-time thing. Part-time private practice and part-time working with someone, working somewhere. So there it is a good balance. You still have someone to rely on, someone for supervision, some consistent case flow, and then you can constantly assess that okay, how much how much can I, how much am I able to do in the private practice? How are my clients doing? Is there any growth? Is there any improvement? Am I feeling confident with CPD and other things that I'm doing? So then gradually with that self-awareness, you can gradually then shift from, like this two thing to the complete private practice. So that is more of self-awareness. I mean, it's you'll have to introspect and keep in mind objective this thing. Another thing is, do you have a space? Will you be able to afford rent and stuff? There are practical things also. Are you in touch with a lot of good psychiatrists? Like, do they know you by your name?
that okay, I can refer this to Miss, I mean to you. So do you have at least 4 or 5 people who will refer cases to you? So see certain things objectively, keep watching, keep introspecting, and then try with this balanced approach initially. Then at some point you'll have to take risk. That's at least my philosophy. Otherwise, though, nobody ever feels 100% confident to start. It's a risk game at some point.
Just start with a like a draft. Start with a draft, like have few deadlines in your mind that for 6 months this is how I'll start my practice. I'll reach out to people, I'll give them my referral, and then eventually you start. Like, don't in the don't get up in the morning and then decide, okay, now I'll start with the practice, because that is a very ambiguous field to be in. Understand what are your pros and cons as an individual, and then start with a blueprint where you will have a timeline that this is 6 months, 7 months, whatever time period, and what are my plans, what are my subtopics, and then at least you'll be confident about where to start. How and who you are as a person, that will evolve over the period of time. And not just in this field, I think with any field. Once you are actually doing it, then only you'll gain the confidence.
Thank you, ma'am, for the very informative presentation. I just had a question that uh, if we are thinking of starting a private practice, then we would require some initial investment also. And could you help me understand more on that part and what we should keep in mind when we are thinking of, you know, yes, and what should be like the first things we should keep in mind when we are starting? What should be the basic?
Frankly, very frankly speaking, thankfully, ours is a field where least amount of investment is needed. Honestly, for online sessions, you need a laptop, Wi-Fi, which is free. Yes, you need to. If you are looking for offline sessions, you need to have a space. So now you will know for your region or your city the rent. In Ahmedabad, for example, in any even in an average area, a normal like 1/3 size of this room will the rent would be around 20,000. That's it. Rest we need a table and a chair. Bus. The fancy sofas, cushions, all of it can be later. The aesthetic therapy room that we see in people's Instagram and LinkedIn is after 2 years. Okay, not initially. The large sofas and couch and recliner chair. I bought it after 1.5 years. The recliner chair. I'm very honestly saying. So initially, you need hardly and some printing costs, report printing, files, notepad, visiting card, brochures, basic printing costs. That's it. So it is not huge. But yes, that's exactly why I said that initially you need to know that you need to be a little sure that X amount of patients or referral systems I have to be able to leave my job or, start this from scratch. So that objective evidence you need to have. I hope I've answered your question. Okay.
Okay, so one thing is the whole session is done here, but as a clinical psychologist, remember your role is not only therapy, right? So there are also like a major part is assessment. So when the assessment comes in, yes, there is some investment depending on like what you want to do. First of all, either you want to do assessment or not, that's a different issue. So if you don't want to do, then fine, it goes. But if you want to do assessment, depend on like what tests you want to do. That's I can start with simple ones. They're like available. Like BKT, I think like 2,000, 3,000. VSMS is free. Bhatia may be like that's part. So if you go to Pearson products, it may be more. But none of our Gazette says Pearson products except for SLD, Whisk is there. That might cost you some 80K. That you can take up later on, or without that you can do MISIC very cheap, like 10,000 something. So these are basic things that you can. I think he started. Yeah, everything already had done.
I would like to thank our chairperson, sir, and all the speakers for this wonderful and insightful workshop. It beautifully blended theory with practical perspectives, and also the seamless transition between the speakers made it even more enriching. I would request Ria ma'am to proceed with the memento distribution ceremony for the same. Okay. We have our chairperson, sir, Dr. B.N. Rupesh, sir. Next, we have Dr. Ravikesh Tripathi, sir.
Okay, for people who don't know, the chairperson gives to the president. So
Because it is instructed by them to visit the farm. It's instructed by
that's the standard practice. I'm completely fine with it. I don't follow protocol. But I want to learn.
Next, we have Miss Shinon Samuel, ma'am. Then we have Miss Rupangi Shah, ma'am. And lastly, we have Miss Avni Vasani, ma'am. Thank you so much. Just a moment, sir. And ma'am, we also have other mementos. So I would request Ria ma'am to once again just come and hand over the mementos. Yeah. So first we have Miss. Yeah. Order से करो. गलत ना. गलत नाम है. First, we have Miss Shinon Samuel, ma'am. Next, we have Miss Avni Vasani, ma'am. Next, we have Dr. Ravikesh Tripathi, sir. Then I would request Ria, ma'am, to give it to our chairperson, sir, B.N. Rupesh. One sec.